Ene, the midwife, community, Chika, the pharmacist, Binta, the veterinary, Sherifat, the dentist, Tamuno, the radiographer, Ekanem, the physician, and the list goes on and on. These are random names of some women in Nigeria who constitute the vital health workforce in Nigeria and globally. We have a dilemma on our hands that gave birth to this phenomenal movement. These women play a significant role, making up 70% of the health workforce. But they occupy less than 25% of senior decision-making positions. So we can all agree that women are not fully represented on the table where it matters. And when they are not represented, their interests will not be duly protected and recognized. So I'm hopeful that today you would have a learning and truly reflective experience from all the conversations, keynote speeches, and all of the interactions that will happen at this event. We are hopeful that you would appreciate the collective efforts and continuous contributions of women globally in global health. Most importantly, we solicit your support to be a good audience, patient with us as we go through the next 2, 3, or 4 hours discussing and engaging. So I officially welcome you to Nigerian launch of Women in Global Health. Please celebrate yourselves. So we're going into the event very quickly. If you could rise up for a quick opening prayer. Thank you. Dear God, we come to you today asking for guidance, wisdom, and support as we begin this event. Help us to engage in meaningful discussions. Allow us to listen to each other, hear each other, and learn from each other. Much more, may goodness come out of all of the interaction and progression. All this we have asked by God's grace. Amen. You may be seated. Thank you very much. So very quickly, we're going to pass around the mic and introduce ourselves. We'll try to keep it short, but we are really interested in knowing everyone. And for the virtual audience, please do us a favor, introduce yourselves, tell us your names, wherever you're joining from, and the organization you either work with, represent, or what you do. We're going to replicate that physically as well. So the microphone will go round from behind, and then we'll hear your name, organization you represent, or what you do. Whatever you're comfortable to share in about 30 seconds, we'll appreciate that.
Good morning, everyone. My name is Atineke, and I work with the Center for Communication and Social Impacts. We're here in Abuja.
Good morning, everyone. My name is Nafisat Salisi Isa. I work with Public Health Department, Health and Human Services Secretariat, FCTA Abuja. Currently, I'm a student for my master's in public health. Thank you.
Good morning, everyone. My name is Faith Iromo. I work with the Pharmaceutical Society of Nigeria Foundation, and we are here in Abuja. I'm the M&E officer. I'm also a businesswoman. Thank you.
Good morning, everyone. My name is Grace. I work with Vaccine Network for Disease Control. Thank you.
Good morning. My name is Allison Varco. I'm a program officer for women's leadership at the Bill and Melinda Gates Foundation.
Good morning. Really great to be here. I'm Ida. I'm a senior program officer at the Bill and Melinda Gates Foundation, and Women in Global Health is a really critical partner. Excited to be here.
Hi, good morning all. I'm Amina Aminu Dore, Country Director for Pathfinder International in Nigeria. Really excited to be here as well.
Good morning, everyone. My name is Katia. I'm a senior program officer on our global policy and advocacy team with the Bill and Melinda Gates Foundation.
Good morning, everyone. My name is Chinelo Henrietta Okonkwo, Assistant Director with National Hospital Abuja and WGH member.
Good morning, everyone. My name is Adiremi. I work with Pathfinder International as the Regional Advocacy Manager for Anglophone Africa, and I'm excited to be here. Thank you.
Good morning, everybody. My name is Vivian Hekwazu. I'm the Managing Director of Nigeria Health Watch. It's especially great to be here with all of you this morning.
Good morning, everyone. My name is Maria Sade. I work for Chemonics International as Chief of Party for the Frontier Health Markets Engage project. Thank you.
Good morning, everyone. My name is Hadiza Moody. I'm a senior
Nigeria. I'm a physician, clinical physician, and also a public health physician. I say this all the time. People like to talk about how, inspiring my work is, but I really, really, really couldn't do it without you. And yes, I really, really, really couldn't do it without you. And it's really not about me. This is not because my slides are not ready, but we will not be doing many things presentation style because the conversation is really not about me. As the moderator said, the conversation is about ordinary women in Nigeria and the work we have been doing. And we all know this story. This story is very, very familiar. It's familiar to me, it's familiar to you. And the work we've been doing somewhat silently, not because we haven't been making the strides, not because we haven't been putting in the work, but because of the way things are shaped. And that essentially is what we want to change. Time for a longer speech, but I just want to tell you that everything that I radiate is what you give to me. Your stories, your inspiration, your energy, everything you give to me is what we're pushing back. So thank you very much. Every time I have called people here, every time I have asked for, there's been no time we didn't get an outpouring. So we know that this time, the time has come. That's for me the biggest check that the time has come, because every time I just raise my hand to need something, I get 10,000 rising up. So thank you very, very much. It's never taken for granted. Let's begin.
Thank you so much. I think we'll give another round of applause to everyone. I didn't want to burden our hands, having us clap after each person, but it's just, I feel empowered standing in this room and just standing with every woman. No offense to the men in the room, but I'm particularly empowered by all the women doing great stuff in different places here. Very quickly, we're moving on to our welcome remarks. I'd like to introduce the speaker in a summary. Dr. Amina Aminu Dore is a physician and public health professional with extensive experience in designing and managing health systems and sustainable development programs, funded by international and national donors and multilateral agencies. She is currently the country director at Pathfinder International, where she provides overall strategic leadership and oversees the programmatic and operational management of Pathfinder activities in Nigeria. With a resounding applause, please help me welcome our warm host, Dr. Amina. Thank you so much.
Thank you, Toyin. First of all, I didn't give her that introduction. I think she found it online, so it was also a surprise to me. But before we start, DJ Samuel, please hit it on. I want everyone to stand up and we'll shake a bit. There's a song that he put in just before we started, and I really loved it. And to me, it just was so personal and really what this whole launch and Women in Global Health stands for me. Hit it on. And dance to it.
Put your empty hands in mine. And scars, show me all the scars you have.
you listen to what it means?
And hey, if your wings are broken, please take mine so yours can open too. Cause I'm gonna stand by you. I won't tears, make a lot of scopes in your eyes. I know you're hurting, but so am I. And love, if your wings are broken, I won't let yours can open too. So I'm gonna stand by you.
Thank you very much. I just love it. It's talking about how we will stand for each other and how we will stand by each other. And for me, that is what women do to each other and women do for each other. So distinguished guests, representatives of civil society organizations and health organizations, women's health advocates, friends and members of WGH Nigeria, all the online participants and members of the press, good morning. It really gives me a lot of honor and privilege to welcome you to the launch of the Women in Global Health Nigeria chapter. I'd like to share some reflections about what Women in Global Health means to my organization, Pathfinder International, and as also to me as a person, because I always keep on saying that I'm glad that I work within an organization that aligns with my personal values, my personal beliefs, and experiences as a woman in global health. First of all, Toyin, the moderator, has talked about the importance of having women in the healthcare leadership positions. And one of it is that evidence has shown that increasing the proportion of women in positions of health leadership would actually accelerate universal health coverage and help us achieve sustainable development goals. And of course, it's because we have more women in the healthcare space, working in healthcare, but very few of them, just 25% of them, are in influential health leadership positions. And when you're in influential health leadership positions, it means that you're part of decision making. If we're not part of decision making, it means we're not able to present our case for us and for the women folk that are working with us. So Women in Global Health movement was born out of the need to challenge this narrative. It is a global network of women and allies from across geographies, across backgrounds. And I think that's why Paige was very excited when she heard many people coming from different parts of Nigeria. So when we come together, despite our different backgrounds and experiences, we're coming together for one thing: to fight for equity in global health leadership. Why we say equity is because, it's not all about only women, it's about both men and women coming together, all genders really coming together to advance equity. That is what we're asking for. So as Women in Global Health, we elevate the voices and visibility of women in health. We position, we connect, and we support women and their allies as agents of change, and we advocate for gender transformative policies and practices and hold leaders accountable for their commitments, because we know it's the smartest thing to do. I work for Pathfinder International, which is, for those that don't know, is a global health organization with locally led and community-driven programs. We support women to make their own reproductive health choices. We envision a world where everyone, even in the most challenging environments, has what they need to be healthy, to thrive, and to live the life they choose. At Pathfinder, we build lasting and trusted local partnerships to strengthen health systems, forging resilient pathways to sexual and reproductive health and rights for all. And our partnership with Women in Global Health is a good example of such kind of collaboration. Working closely with organizations like Women in Global Health Nigeria complements our mutual objectives, and together we can achieve greater impact. So as a woman working in the global health space, Women in Global Health represents what I stand for. It is a long overdue safe space to discuss the unique issues affecting women in the healthcare industry and support each other to achieve our full potential. When I began my public health career about 2 decades ago, I did not have a support system to guide me in taking those tough decisions that needed to be made as a young, and I must add, confused medical graduate. I'm sure many of you would recall that time that we graduate and you're just confused. There are too many paths to take, there's too many questions to be asked. So at that time, my choice of career advancement in public health meant stepping out of the norm without a mentor to show me the way. There were not many women in healthcare leadership positions I could look up to and ask those personal questions that only women with lived experiences could understand. But at this stage of my career and as the country director of Pathfinder International in Nigeria, I am committed to supporting young women to have a better career experience in the global health ecosystem. This is because women's contribution is critical to advancing economies and making our world a better place. As women, we belong everywhere we choose to be, either at home or in the boardroom. Partnering with Women in Global Health means investing in better global health. The organization, that's Women in Global Health, started in 2015 with only 4 passionate women that decided to make a change. And you'll hear from Rupa as we move forward. So currently, I'm pleased to announce that Women in Global Health has nearly 50 chapters and around 5,500 members and over 100,000 supporters. At this point, I would like to especially recognize the Bill and Melinda Gates Foundation, represented by the amazing women on this table, for their support towards Women in Global Health movement. We cannot do this without you. We as Women in Global Health, we are nurses, we're midwives, we're doctors, we're public health professionals, we're health policy makers, we're community health workers, we're researchers, we're pharmacists, and we're private health sector workers. We're everyone and everywhere that works for women's health and for the health in general across Nigeria. On behalf of my organization, Pathfinder International, I'm honored to be a critical part of this movement in Nigeria. I'm really energized by your interest in joining us to change the narrative about women health leaders and to increase visibility. I welcome you to this historic launch as Nigeria joins other countries to kickstart the Women in Global Health movement. By the way, we're the largest and most promising economy in Africa, so I don't know why others have come before us. But anyway, we're glad that at last we are here to launch this movement in Nigeria. But please take time to have fun, to unwind, to interact, and to form lasting connections. There's ample space behind us to network and to know each other better. And for those online, please be sure to browse through the participant names and send that direct message or DM to introduce yourselves to each other. But once you join this movement, that's Women in Global Health, then you automatically agree and commit to our terms and conditions, which include supporting each other and mentoring at least that one other woman to feel empowered and to take that bold step to advance her career. Thank you for coming. And to our online participants, thank you for joining the virtual launch. Together, we can build bridges, form lasting partnerships, and surmount obstacles to reach our desired health system objectives. Welcome once again, and wishing us a memorable launch. Thank you very much.
Thank you so much, ma'am. Well summed up. I hear support, empowerment, collaboration, all the things that we hope to get out of this and other subsequent gatherings. We'll have a few goodwill messages, and we have one that was pre-recorded. Dr. Elena Nwadinobi really wanted to be here but could not be here, unfortunately. However, we're fortunate to have her pre-recorded goodwill message, and we'll hear 2 other goodwill messages from participants who are present here. Dr. Eleanor is the president, Medical Women's International Association. Please let's have a goodwill message.
Greetings. I congratulate Women in Global Health, the Nigeria chapter, on the occasion of their launch today. And as we look at the theme of redefining women's leadership for health equity, I can identify with that as the international president of the Medical Women's International Association. I've come to realize how immensely important it is to look at women in all their diversity and in all their vulnerabilities. We have to be intentional and we have to be strategic around mentoring and around succession planning. And with those few words, I wish you all the very best in the launch event today. Thank you and God bless.
Amen. Let's celebrate her, please. Thank you so much. Our next goodwill message is from Dr. Maria Saleh. She is the Chief of Party of USAID's Frontier Health Markets Engage project. Please give her a round of applause.
Thank you very much. Good morning, distinguished guests. I'm very pleased to join you all today to celebrate the launch of the Nigeria chapter of Women in Global Health. Toyin mentioned earlier that more than 70% of the health workforce is made up of women, and very few are in leadership positions. We may ask ourselves why this is. We know some of the reasons. Some of it, from the educational status of women. Women are not encouraged to dream big, to be leaders. Men are seen traditionally as the leaders. So very importantly, we need to see more women that we can look up to. Personally, I've looked up to Dr. Amina for decades. Yeah, we went to the same medical school. She was my senior in medical school. I made up my mind pretty much early to go into public health, I think in my 4th year. So I just thought, okay, we need to make a difference and I can't do this as a clinician. And I went into population health. And when I got out, I saw Dr. Amina in the space. So immediately I had someone to look up to. I have someone to speak to. I have someone to chat up on WhatsApp if I have a question, if I need something. And that's very important for many women. I also see in the room Hadiza Moody, who went to school with me, secondary school. Yeah, nice to see you here as well. So I'm very happy to be here. This is a safe space. I feel so welcome, so warm. Nice to see so many women. And I look forward to welcoming many more women who are just thinking about what they want to do as they come out of nursing, medical school, even School of Health Technology. They too can dream big. So thank you very much and congratulations today.
Thank you so much. And our last but not the least, we have Mrs. Vivian Ihekweazu, the Managing Director of Nigeria Health Watch. Thank you, ma'am.
Good morning, everybody. It's really such a pleasure and an honor to really be here this morning at this launch of the Women in Global Health Nigeria chapter. I think it's been long anticipated, and we at Nigeria Health Watch are more than excited, so excited to see that it's finally launched. I think so much has been said here about the underrepresentation of women in leadership positions, especially in the health sector. And we all know what happens when women are not sitting at the table, where decisions about our lives and our bodies, etc., are made. So this chapter, I think, is critical in collectively all of us pushing for this to change, but also pushing for more he for she champions. Men support men and women support women and men. So we all have a role to play in ensuring that we bring on more male champions to really push for more equity. I speak from the perspective, I have 2 sons, and I see it from the home. We all have a role to play in ensuring that men, boys grow up to believe and know that women have an equal share of leadership positions in Nigeria and everywhere else. So this morning, I'm really excited, as I said, to be here on behalf of Nigeria Health Watch. We push collectively always for issues that affect women in Nigeria and also globally. So today, I think this marks an important chapter where we push, we work with our gender advocates, we work with men in leadership positions to ensure that we are sitting at the table, because this has to change. We do so much work, but we don't get heard enough. So on behalf of my organization, again, I'm happy to be here. Thank you.
Thank you so much. I think the recurring themes are around empowerment, collaboration, warmth, mentoring. He for she champions. I like that phrase. It will live with me for a long time. He for she champions. Succession planning. Awesome goodwill messages. Please give them a round of applause again. Thank you so much. When Dr. Amina was speaking, she made reference to strong support from Bill and Melinda Gates Foundation. We have representatives here today who would be giving us an opening remark, and then we'll move on with the rest of the event. You're welcome.
Distinguished guests, partners, hosts, it's truly, truly energizing to be in the company of so many women that are thinking creatively about how to advance women's leadership in Nigeria. At the Bill and Melinda Gates Foundation, we're truly grateful to have deep partnerships with organizations like Women in Global Health, and many of you here in this room and online today. We know that there is not a single country in the world where women are playing equal roles in setting policy, allocating resources, leading companies, or shaping markets. In many countries, more women are working than ever before, but compared to their male counterparts, women still are not earning as much, they're not rising as high, they're not being afforded an equal voice at work, in their families, in their organizations, or in the society. At the foundation, our North Star for gender equality is the UN Sustainable Development Goal 5. At the current rate of progress, the world will not reach this goal until 2108. I'll say that again, 2108. That is unacceptable. In certain rooms, I hesitate to even give this number because it can feel so deflating and so disheartening. But in this room today, I see this number as an invitation. Everyone in this room has a role to play to getting that number down. This is an invitation to think collectively about how to accelerate progress, invest in new ideas, push policymakers to address barriers, and tackle those deeply held social norms and attitudes to create lasting change. I want to spend a few minutes to talk about a specific aspect of gender equality, which is why we're all here today, and that's leadership and power. Before joining the Gates Foundation, I worked in youth empowerment, training groups of students from all around the world, young journalists, young activists, and truly the next generation of leaders. I saw time and time again that the young women in the room would shrink their voice, hide their ideas, and constantly take a backseat to the boys in the room. One of the girls painfully told me that her family in her village back home was mad at her for coming to participate in an American leadership program because it's not what good girls did. But the truth is that we need their voices, we need their ideas, we need their energy, and we need their leadership. Now, 10 years later, I often think about these students. They're entering the workplace, they're starting their own pathway to leadership. What is the world missing if these girls are still shrinking their voice and still hiding their ideas? At the foundation, we're approaching the concept of women's power comprehensively with a whole division dedicated to investing billions in gender equality. Beyond the work of our gender equality division, We work to ensure that the entire portfolio of programs have gender intentional and gender transformational investments. Because we know, and I don't need to tell you this, but we know that you cannot eradicate polio, you can't combat HIV, you can't solve hunger without making gender intentional and gender transformational approaches. Our co-chair, Melinda French Gates, she often says, the face of suffering is so often a woman's, the face of power is so often a man's. When the face of power remains the same, so will the face of suffering. So we work to change this face, to position more women from all backgrounds to make decisions, to control resources, and to shape policies. We think that power at all levels, whether it's in the home or in the public space or in the workplace, are linked to the development of nations. Within our own team, the women's leadership team specifically, we focus on professional women in the formal sector, usually mid-career. We focus in 3 specific sectors: health, economics, and law, that have an outsized influence on policy and resource allocations. We take 3 specific tracks in this strategy. One is individual empowerment, where our goal is for women to be able to enter their careers, to rise in their leadership, and to thrive once they get to those leadership positions. Organizational change, where our goal is to increase representation, agency, and influence in sector-shaping institutions. And lastly, societal impact, where our goal is growth in the proportion, influence, and power of women all across society. We are truly lucky to have partners like Women in Global Health walk hand in hand with us to achieve these goals. The truth is, Women in Global Health was advocating for women's leadership in the health sector way before the Gates Foundation was talking about this. Way before we started to invest in the critical driver of change that is women's leadership. Early on, our team learned from them, we borrowed their messages, we studied their strategies, we engaged their leadership. Today, we're proud to be investing in this incredible global movement. Power is created when women come together to achieve this collective success. I was fortunate to witness this power this past September when I joined Women in Global Health in Nairobi and joined women from all across the globe. We think that this same formula of determination, collaboration, and political will can be applied for other stubborn barriers across gender equality, including women's leadership. We all have a role to play. We all have actions that we can take today, tomorrow, next week, and next year. We can all challenge ourselves to expand our conception of leadership, encourage our own organizations to examine what it's doing to retain and promote women within their organizations, and we can all advocate loudly for policies that will empower women in our society. We have this opportunity today, tomorrow, to work alongside Women in Global Health and people in this room to tackle inequality at its root and put women on the fast track towards power, influence, and leadership, and to get that unacceptable number of 2,108 down. Thank you so much for your partnership.
Thank you so much, Alison. Very powerful message. As always, there are lessons to pick, so many. Yeah, you spoke around leadership, you spoke around power, you spoke around energy, ideas that women should rise and thrive. So I'm going to make us do an exercise before our next agenda item. We're going to go to at least 3 women and tell them thank you for all you do. Let's make it 5. It's an empowering atmosphere, so let's just ride on it. Thanks for all you do. Thank you for all you do. Thank you. Thank you. not 5 yet. I'm counting. I can see those of us yet to stand up. I love the energy in the room. I love the warmth. I love the energy. Thank you so much. Thank you. I love it. Women never miss an opportunity to hug. I love it. I love the energy. Thank you so much. And thanks indeed for all that you do. It doesn't matter if it's amplified enough, but you matter and all that you do counts. Thank you so much. My own hug as well. Thank you. All right. Before I bring on, I think just researching about her, I call her a force. Before I bring her on, I'd like to speak a little bit about her. She's going to give us an overview of Women in Global Health Nigeria, what it is about, when we started, where we are, and where we are headed. Her name is Dr. Adekbeju Adeniro. She is an experienced physician of 17 years, combining clinical expertise in acute adult medicine, as well as public health experience and skills, focusing on local lessons and solutions to universal healthcare coverage in Nigeria. Dr. Adeniro is the national co-chair of the Women in Global Health Nigeria, which is the reason we're here, where she leads initiatives and advocacy for gender parity in global healthcare leadership in Nigeria. She believes that low and low middle income countries' health systems have significant insights to add to global health policy, and aligned her career in the direction of making these contributions palpable. With a resounding applause, please welcome Dr. Adekbeju.
Thank you very much. Kind of said it before, but once again, it really isn't about me. And I know you're used to people saying that I'm really not being falsely humble or something like that. No, it really isn't about me. So I had several slides, wrote it several times, and each time was just not enough. So I'm going to speak from the heart, like I sometimes do. And I hope that we could, and that's kind of like the same approach that I hope we will do at the end of the day throughout. We speak from the heart. And I'm sure I'm in the room with the right energy. So I'm going to start with what it is to be a Nigerian girl, because that's all what we have in common. I'm starting that story from there. And I grew up like a Nigerian girl. And I heard some people giggling because we know what that means, right? You're not particularly the golden child in the house, right? As far as attention is concerned. But somehow, you were also the one that was the most dependable, and you were expected to be the one that was the most dependable. You were the one that behaved, right? You were the one that the family name must not spoil through you, okay? You were the one that had to always have your act together. Physically, you sat with your legs together, you were prim and proper, because, you represent the house for reputation's sake, right? But when it comes to who takes the decisions in the house and who is the, I will speak in Yoruba, I don't know what it is in Hausa, so I'm going to ask you. In Yoruba, we call it, so in Igbo, I think it's the Diokpa, right? When it comes to the Diokpa, it's like the staff of the house. It's not you. If Yoruba, you call it the Oluomo. That's the head of the children. It's not you somehow. So there's a Hausa equivalent, I think, of what is the scion of the house. You're not the one that is thought of. Even when you're as the first daughter, how many first daughters? Thankfully, I'm not. How many first daughters? You know, you're a co-parent, right? So you're a junior mommy, and you do all the work, and somehow you're not thought of as a scion. So that was, first of all, our training and our entrance into our world, first of all. And it kept repeating itself in almost every space that we were in socially. Women are the ones that hold the systems together. It's our behavior, our virtue signaling, you know, all those things. We kept the society sane and structured, you know. You can't shout too much, you can't do that. And yet somehow we're not the ones in the room. So for me, that was my experience. And I grew up in a house that my understanding of it wasn't that it was even a dysfunction. You know, so I didn't even label it a dysfunction because it was supposed to be, you know, normal, right? So I behaved myself a lot. You won't believe I used to behave myself. This is why I don't behave myself anymore. I behaved myself for several years, so I don't anymore. And then I did the right things. I went to medical school to become a doctor, no less. You know, you don't get more behaved than that. And only to find, yes, a whole doctor, you know, behave yourself. You go to school, you read the books, you behave. And only to find that it didn't save me, right? And as a doctor, I was supposed to be, on some level, one of the most fortunate, one of the most privileged women in Nigeria. You don't get more privilege than that. Whether you started out middle class or lower class, by the time you became a doctor, you somewhat became middle class, right? I should be above it, to my surprise. And I think that was when I just stopped behaving. To my surprise, I found that even being one of the most privileged professions, and after years of working hard in that profession and being in, you know, so you go to senior doctor, like, you know, you don't, for real, you don't, it doesn't get better than that. And yet, you see the systems, you do the work, and you're not just that you need to lead, but you can't see how this is helpful for your gender. You see the results, and you really can't see how this is helpful for your gender. So I like to speak about how I'm both a clinical doctor and a public health doctor. And for anyone that figured out what they wanted to do in life, congratulations, girl, that wasn't me. I didn't know what I wanted to do in life quick enough, and, you know, tried a couple of things. And then when I thought about public health, I think someone said, I knew we weren't doing enough in the clinic. I think it was Dr. Saleh. I agreed. I knew that every time I saw somebody in the clinic, I was seeing only a tip of what was happening outside. And I knew that we weren't necessarily able to make the full impact. So at the end, you know, at the back of my head, I knew we had to take what we were doing into the public and go into public health. So I wanted to go into public health. And like she said, I looked around and I couldn't find anybody to tell me, this is how you do it, this is what you do. And so I kept on. And one of the advantages of also knowing what you were doing early, I think Dr. Amina said this, signaling to the young girls who are coming in was very important. But I'll tell you another signaling that was important. There are also people who are not necessarily young, and then they pivot, and life happens, right? So you're working, and we might say, oh, we want the younger ones to come in. We also want people who the light bulbs go off later in life, like it did for me. I didn't know what I wanted to do. I didn't know this would happen. The light bulb came later in life, where you were supposed to be somewhat fixed already, right? And the decisions for a woman in this society, once you make them, are almost life binding. You make one decision and it almost feels like you can't say, oh, nope, you know? You can't just say, whether it is you choose a career that doesn't fit you anymore, you choose a marriage that doesn't fit you anymore, you choose where to live that doesn't fit you anymore. We can't easily, you know, change our mind and pivot. And that's not the case for men. You know, if you want to pivot, the first thing they'll tell you is, can a woman have it all? I've never seen anyone ask a man if he can have it all. You know, I've never seen. I've gone to conferences where older women teach me how to have it all. And I'm grateful for that. But nobody has asked a man if he could have it all. Nobody has asked him, what if you decided to want to be a sailor in your 50s? They'll say, oh yeah. They almost laugh. It's all right. He can cope, right? Because he can say, I'm taking a break from my family and family life and responsibilities. And then he pivots. It feels like once you're a woman, you make the decision and you have to stick with it because you have to behave yourself, right? So I very much recommend no longer behaving yourself, right? I very much recommend it. Stop behaving yourself, it doesn't matter. And have the strength to be badly behaved. And what that is you are more in charge of your life than they would like you to think. And you are not the one that is responsible for holding up the system. You see the wars? It's not us. Abi? So we're not the ones causing the trouble, but somehow we're the ones to keep the sanity in place. So this whole virtue signaling where the other systems make a mess of things and then we come and sanitize it with our behavior. Let me use Nigeria. It's a scam. Don't fall for it. So that's my background story. The permission for women to no longer be well behaved. It's bad behavior that got us challenging this. If the systems in place led by another gender have not worked, 2108, it's not working. It's not working. And guess what? They sat down on this, They sat down on this. They know it's not working. So at the very least, I can't predict what will happen if women get in this space. I have a fair guess. But I can predict what will happen if we don't change it. It's like we all know doing something over and over again doesn't make sense. So it's time to at least, throw something else in it. Let the women who do the work speak up and let their words make meaning. The overview that so I have just 5 quick steps, the way I think about it in my head, is we know that there's a triangle with women at the base, right? And the strongest point of a structure should be at the base. So we already know that we hold the base up, right? And we also know that as the shape goes up, we are less and less represented. So it's a triangle, okay? So the first thing is we need to get the enthusiasm to, first of all, recognize there's a triangle that keeps us at the bottom and that we're falling off. And then at the top, there's practically no women there, both in numbers and in action. And as we go on, we'll explain what that means. I can't see enough women in the systems. So recognize the triangle. When I didn't recognize
I'm not going to spoil my piece. Is this Mohammed? Thank you. This is the bulletproof. Okay, let's go. We're going to Garki. Horton Suits. The name of the place is called Horton Suits. Horton Suits, the hotel in Garki. Take it. It's near that point. Yes. Hmm? I'm charging. Let's go. Moto meme ya change time.
Fatima, you're on speaker. Fatima, you're on speaker.
The Bill and Melinda Gates Foundation. Alison, Ida, thank you very much. Thank you for being there at this time when the women in health, in law, and in economics, which, if you think about it on a health system point of view, are actually the same. There is no health without law. There's no health without economics. There's no economics without health, ad infinitum. So we are very grateful for what you do and the time that you have come in here today. And we just want to tell you 5 things that have been possible palpably possible for us because of what you've done for us. So Women in Global Health was established in 2020. As of today, has 601 chapter members all over Nigeria table. I'll give a snapshot of some of the activities we've done. We led a campaign that focused on bringing awareness to inequalities that women face in the health sector in 2020. We had, as of 2020, 3 major health tech organizations included gender as an essential part of their leadership as a result of these campaigns, MDOC and Helium Health. And because of that, some more programs for technology in health for younger women were designed and implemented. We're part of the national advocacy efforts for quality maternal health by elevating women's voices and experiences for better quality maternal health. We contributed to the WGH State of Women in Leadership report in 2022. We participated in the Build Back Equal collaborative blog series, and we were able to support the advancement of women's appointments in leadership roles in the global health space. The thing that is unique about us is that we are women from the global south. That has been very important in our movement. Because as a woman from the global south, there are 2 important, but not the only, levels of inequity that I face in all these women. 1, as a woman. 2, as a Black woman. And all the women who work in the global, anyone that works in the global south, so there's a ranking order, and doesn't look good for where we are. So being able to amplify voices of women who work in the global south, in global health, is very key to what we do. And in our 5-year strategic plan, which I've basically spoken about it already, is what we will be leading with. That is what you enabled us to do. And because of that, we want to give you a round of applause. And I'm going to speak about how they did it. And they might blush, but you know. So BMG Funding has supported WGH to catalyze action around the Generation Equality Forum and leverage commitments to end unpaid and underpaid work in health systems. It's able to advance women in leadership in the health sector by supporting capacity building of WGH chapters and enabling them to engage more deeply in sustained policy transformation work. The reason why we were able to get this chapter up structurally, beyond enthusiasms, beyond friendships, beyond sisterhood, was because of their support, BMGF. We were also able to conduct national level research on women's leadership in the health sector. I'm very proud of that one. So we were able to gather data on where are women in the health sector and where are women in leadership in the health sector. With me are my researchers, my sisters, who went onto the field. And I want to say one of the things that we are very keen on is that women who are physicians are somewhat, we're not on top of the, on the triangle, but we're somewhere in the middle. The real key, which one of the research grants allowed us to see, was women who work in the community health workers, right? So if I'm not safe, and I'm with this amount of privilege, doctor no less, then imagine what is going on to women who have spent years supporting global health on a public health level as community health workers. A lack of structure in careers, a lack of remuneration, a lack of recognition. So while there is no obvious door, right, to stop them from getting into leadership, how does somebody who doesn't get paid rise to leadership? How does somebody who often cannot get to work where they're posted to, last mile health delivery, get to leadership? How does somebody who's not safe from sexual harassment at remote health service delivery rise to leadership? So they won't tell you the door is there. How does somebody who has been a community health volunteer for 17 years? I mean, there were stories you heard on the field. You've been volunteering for 17 years. That's somebody's lifetime. And then you ask them, what is your role? What's your title? I'm a volunteer. No role, no title, no remuneration. So when she thinks about herself, is she going to think herself as somebody that can challenge the system? No. And it's structural. Many of these, and then they use these gaps like, oh, if you want to rise in your career, you need education, you need a degree. Many of these women volunteered to be able to afford to go back to school. 17 years later, no school, no money, no career, and you're doing the work. And the entire of global health rests on the primary care system and primary care delivery. So isn't it a security risk that global health is funded in many systems in low to middle income by free labor? No, it's not free. No, it's unpaid. Unpaid. Pardon me. You know, it's unbelievable. But more on that later. The researchers are going to talk about that. And the last one, for the Bill and Melinda Gates direct support, universal health coverage advocacy. For me, UHC is equals to PHC is equals to CHW. It's very simple for me. On the community health workers, because the biggest aspect is the human resources to do the work. So far, we've been on human resources, on hope and prayer, right? So everything for us, for universal healthcare, is to be targeted at primary healthcare system. And if we're serious about the primary healthcare system, then we have to be serious about the community healthcare worker. It's just one sentence for me. It's not more complex than that. They will tell you it's more complex than that, of course, but it's not. So if you pay community health workers, you give them a structured career, you allow them to rise, then you will deliver PHC, and then you will deliver UHC. I'm very, very honored to be here with all of you and basically be a conduit to share your stories and your experiences. Thank you for honoring us, and thank you. I'm very excited about what I see in the future. Thank you very much.
Thank you so much. That was very heartfelt, passionate, and well delivered. I've told my mind, if you forget anything, don't forget, don't be well behaved. But I think another way to coin that I want us to always remember is women should live audaciously, defying conventions, questioning the things you feel you need to question, and making a difference, one girl to woman at a time, so that we can really, really be part of building the succession plan for the future that we hope to have. So things are getting a little more interesting by the minute, and there's a little tweak to our agenda, so I just wanted to communicate that before we move on. We'll be taking the panel discussion in the next 20 minutes. I imagine that some of us already have burning comments or questions. What I will encourage is that we begin to note them down. We might be passing around, if you don't feel like asking the question directly, we'll pass around sticky notes or simple sheets so you can note your questions and comments, and I'll pick that up and share with the panel. So just to introduce the panelists quickly, and Dr. Kweju would be moderating the session. We have already met Dr. Kweju, so I think we give her a round of applause as she comes to sit. Next up, we have Dr. Fatima Lawal La. She's a public health physician. She works with the Kwara State Ministry of Health as the State Disease Surveillance and Notification Officer, or the focal person for cancer control with over 10 years cumulative experience in both clinical and field practice. Dr. Fatima is passionate about health systems research, and her research interests revolve around global health, field epidemiology, health policy analysis, healthcare financing, and health service research. When she's not busy doing all this awesome work, she loves to read good books and visit new places. A round of applause for her, please, as you take your seat, ma'am. Thank you so much. Thank you. Please make yourself comfortable anywhere. Thank you, thank you. Our next panelist is Mrs. Hadiza Modi. She's a senior lecturer in Aliko Dangote College of Nursing Sciences in Bauchi State. She's a member of Parasitology and Public Health Practitioners in Nigeria, member of West African Network of Emerging Leaders and Researchers. I told you we're in a room with powerful women. And also member Health System Global since 2016. She has participated in many research projects in Bauchi and Sokoto states since 2009. Initially working as a field supervisor and later as a senior supervisor. She is a member of Women in Global Health and has participated in the research on the state of women and leadership in health in Nigeria. Please, a round of applause for Mrs. Hadiza Modi. Thank you very much, ma'am. We're happy to have you. The fourth panelist, and not in any way the least, is Dr. Egwim Adana Vivian. She is an obstetrician and gynecologist and a public health officer. She's a consultant with Nnamdi Azikiwe University Teaching Hospital and also a member of the Effective Clinical Research Unit of the hospital. She's a member of Research Group of Women in Global Health, Scientific Committee of Medical Women Association of Nigeria, and State Coordinator of Society of Obstetrician and Gynecologists, the Imo State chapter. She's a seasoned public health officer with much interest in quality research. When she's not busy doing all this awesome research, she loves cooking and reading. Please welcome Dr. Adana. We look forward to really engaging discussions to be led by and moderated by Dr. Kweju. Thank you so much.
Thank you very much. And welcome. So on this panel, we want researchers who went on the field to basically talk about what the data showed. I will just give an overview, and I have already, that this research was supported by the BMGF, once again, wonderful. And what they wanted was to ensure that the advocacy that we were putting forward was on palpable numbers. It didn't, so we knew the lived experience of women all over the world. And one of the things that has been very helpful for me as a woman in the global south was to find that I really thought it was a us problem. Oh, this is the global south because, you know, the patriarchy here, and to find that women in the global north were having similar problems to me. And I was like, what? Yes. And I was like, what? I thought you were safe, or at least safer than me. But apparently, well, nobody is safe without each other. And so it was important to go beyond just our lived experience and say we want actual numbers. Because if we don't use data, they will accuse us of the thing that they always do, histrionics. Women have come, they're speaking from their emotions right? So it was very important to move the conversation beyond our emotions, beyond my lived experience as a Nigerian girl, beyond your lived experience as a Kenyan girl, beyond the lived experience as an Indian girl, right? And have the data, because that's how we keep them accountable. So there were two researches that Bill and Melinda Gates supported in 2022, and one was the state of leadership, and then the pathway of community health workers to leadership in Nigeria, in Kenya, and in India, and in Ethiopia, 4 countries. And I have to say, because it was a multi-site, multi-country research, one of the things that stuck out to me when we would do our meetings and compare notes was, it didn't feel like we were looking at 4 countries. It felt like we were looking at one country 4 times, because the data reached saturation really quickly. The quotes, because it was qualitative research, the quotes, I mean, I was speaking in Nigeria or listening in Nigeria, and I could have been in Kenya. The quotes were so similar, sometimes it felt like maybe I just made a mistake, and no, it was a different document, but it was so similar that the saturation was so quick that we had to go back again and look at it, reanalyze it. No, maybe we may, make sure it's very, researchers, what's that word that you're looking for when you, randomize it some more. Maybe you didn't randomize enough, as many times as you tried to randomize, it was coming back very, very saturated very quickly. So we had this research where we collected qualitative data from 6 states representing the 6 geopolitical zones in Nigeria: Lagos, Kwara, Imo, Enugu, Bauchi, and Kaduna. We wanted to have all the researchers here, but logistics and planning didn't make that possible. So what we did was to have 3 of the very powerful women who worked on and I have to pick them up, you don't even understand. They worked tirelessly under a tight timeline, and not just a tight timeline, they worked against many obstacles. Like I said, it's very hard to get that data. It's very hard to get into those places and ask those questions. It was very hard for them to go into the ministries. It was very hard to go there and get access to. And we found that it's probably not deliberate, if you know what I mean. Right. So against all obstacles, they had to throw everything at it, their expertise, their wiles, all of that, to get into the field. So because of that, please, 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 a wonderful round of applause for the wonderful researchers. So that's where I'm going to start from. What was your initial experience? First of all, when you saw the topic, because we had an open call for researchers, when you saw the topic, what was it that made you say, yes, this is something I want to be a part of?
Okay, good morning, everyone. I'm a researcher and I have been working, I am also a lecturer. So I had been working with the State Ministry of Health on maternal health issues and having a lot of researches. So when I just saw these research coming, I said, yeah, this is another opportunity for me to see the state of women in leadership in the healthcare sector, because the research we had been conducting researches at the grassroots level, that's in the community level, in order to see the impact of some certain interventions on how we can reduce maternal and child health mortalities in the state. So having to work with women in global health, it really made me to become interested in this research work, because it also has to do with the health sector, and it also has to do with how these women, how these people that are attending to these women that we are working with, what are their challenges, what are the things that they need, how they are going about their work and at the health facility level. So that was one of the things that made me to become interested in this work.
Okay, thank you, Dr. Peju. And I must say that I want to also say thank you to Bills and Melinda Foundation for this, because it's something that I'm a program person. I have oversight functions with the local government and the health workers. And most times we'll go on supportive supervision, we'll go for monitoring. And of course, we do evaluation of these people and we'll bring up a report. But it's something that we have not done in like a scientific manner, in evidence-based, like having it published and all. So when I saw the call, it's a kind of opportunity to be part of making a statement about the status of community health workers, their challenges, the pathway to leadership, and overall it was a very wonderful experience for me, and I'm so happy I was part of that research. Thank you.
All right, thank you. The first thing that came to my mind when I saw the topic was my own personal experience. Then in the health sector, we're used to the end users. We hardly do researches that has to do with the providers. So that's why recently researches that will call for the providers, health workers are so important, because these ones are the ones that provide. So when I had the opportunity to evaluate or study their perception in terms of leadership roles, it was an exciting moment for me.
No, just hold the mic.
All right.
So, do you think, and did you find that there is a possible path to leadership for a community health? Stop sighing now. She's so sad. That there is a possible path for community health workers to reach the top of health leadership in Nigeria, from what you saw?
Okay, from what I saw, there wasn't really a structured pathway, a recognized pathway, but with the study and from what they could volunteer, if we are very serious about creating a pathway, it is something that can be actualized. So importantly, they are aware that through career progression, they can achieve the leadership roles. But at the same time, many of them were of the opinion that you really need to know somebody. It is not just about your career progression for you to occupy those senior role positions. So, but if with what is going on here, I'm having the future in mind, there's something structured for these people, they will be able to achieve those roles in future.
Dr. Fatima, what's your opinion on if there is a structured pathway for community health workers to get? So, to be clear, community health workers in Nigeria are almost 70 to 80% or 90% female. Yeah. So it's a very gendered sector. So if there is no path to leadership, do you think, and I'll come back to, no, the question is for Dr. Fatima. Do you think that the lack of pathway to leadership for community health workers has anything to do with the fact that it is a heavily female gendered job?
Positions in order they can be able to make decisions, because some of them said, one of the community health worker I had interaction with said she wants to become a commissioner of health because she wants to change the health system, especially at the primary health care. She wants to make sure that the primary health care is well equipped with all the facilities at the secondary health care. We all know that the primary health care is for preventive and measures, but then she had the passion for that, but she told me that I know I cannot become a commissioner of health because I am not a medical doctor. I'm just a community health worker. So they have the interest and they really want to do it. So if they can rise to leadership position, they can make decisions and control resources, and then we'll be able to achieve universal health coverage, and the health system will work out well.
Thank you, Dr. Hadiza. So in recommendations, I want to give the mic to Dr. Adana because I want to pull together all the things you said. In the North especially, we have a lack of female medical workers, right? Because the women are not getting into as many schools to complete what, to have enough female health workers at the top. Are you suggesting that in order to then combat maternal death and morbidity, community health workers are a stopgap to bridge the gap between not training enough full medical doctors and still being able to give some kind of health access to women? And then how do we manage this, getting the community health workers to do the doctor's job in a structured way? Are we saying rethink what health delivery looks like so that more community health workers can do more work, even though that will be taking care of the problem we have at hand and it's not the long-term solution? But we cannot throw away a solution that can help and save women right now because we're waiting to train more women in school. I think that's what I understood. We can utilize community health workers to bridge the gap of female physicians, say in certain parts of the country, instead of saying that we're going to fund direct education and fund behavioral modification, which will take a long time. It's a sustainable solution, but it will take a long time. Are we saying we can use community health workers, which, we can task shift? Is it, is that your recommendation or did I get it wrong? Dr. Hadiza, we'll let Dr. Adana agree or not, and then we can go into recommendations and close out.
Okay, I know that the community health workers are the ones that deliver the healthcare at the community level, that's the rural areas. But that doesn't negate the fact that you have health centers where doctors and other cadres work. So in the Southeast, you have structured health centers, primary health care. The only challenge is that there is no sense of belonging. These ones don't have active participation at the other tiers of hospitals, like the national federal institutions. So sometimes we tend to regularize the payment for doctors, nurses, even the community health workers at the national state levels. But we tend to forget these ones because from the ones I interacted with, some of them are aware of what it takes for them to be leaders. They are also aware of the limitations of their services. They also understand the collaboration between the community job as a health worker and referral system, because they have informants as non-health workers when it comes to disease surveillance, disease reporting. Then they, as community health workers, especially the chief community officers, they have accommodation so that they will be very much accessible. The only challenge is that there is no motivation, no remuneration for this. The only solace they get is from the community. They get applause they get applauded by the community. They get some other things from the community. Some of them will tell you that the community provides accommodation. So they don't tend to pay for rent. They don't spend money on certain things. Some people, the influential people in the community will even cater and pay their children's school fees. In such a manner, they tend to continue the work, even without motivation. And a few others were able to tell me that they have done a whole lot. They have continued medical education. Some of them have masters in public health, yet they cannot attain the leadership role. So what is the issue? The issue is that when it comes to decision making, nobody remembers primary health care. If you can think about it, in Nigeria, the National Primary Health Care Coordination is done at the state level. You now ask yourself, why the state level? What happens to the local government area? So everybody reports to the state. Why won't these people be assigned the role to foresee all these administrative things and work with? Like the executive secretary in my state for the primary health is a doctor that never worked in the community health. She did her training in the tertiary hospital After the training, she became a consultant. She did 1 or 2 public health jobs. And within 5 years, she's now the executive secretary. So the question is, what about the community health worker that has been there for over 10 years, 5 years? So these ones are well equipped. They understand what it takes. They know. So I don't think they are there to do some job, bridge the gap, but they will not replace the jobs of, because some states have good health, whatever, and they may not need the community health worker to do certain things. You still have to refer when you need to refer. Thank you.
So, from the discussion, you were talking about the community health worker not having, I couldn't get that. I missed that part.
From Dr. Hadiza's position, what I understood was that community health workers could, in states where we don't have enough physicians, especially for delivering women-centered service delivery, community health workers could bridge that gap within the primary system. Dr. Adana agreed and then diverted where she said, these are 2 different health service delivery. Medical health service delivery is different. We cannot use one dysfunction to try and fix another. There is a need for public health intervention and investment on its own. Disease notification, disease tracking. The doctors are not going to do that. Public health. We had COVID. We had a pandemic. And our response in Nigeria, it wasn't the technology that saved us, because we didn't get the technology in time. What saved us was skills of community health workers, tracking, information, behavioral modification. Till today, somebody is still telling people to go and be vaccinated for COVID, and it's the women. It's not the doctors, not me. I'm sitting in my own drinking coffee.
I get the perspective.
Okay.
So what we are trying, I want to kind of agree, because that's what they are doing routinely. Task shifting is what is happening at the primary health care system now, because one of the reasons is because of the limited staff. When you get to the rural community, especially those last mile communities, you realize that you only meet community health workers. You don't even see any other cadre of staff there. And those communities also need essential medical services like family planning, antenatal, routine immunization, and all of that. So we can only train them more. Of course, their partners, the national government and the state government are doing very well in training the community health workers so that they can actually fit into the role of doing essential services, delivery, antenatal services, and all of that. But it is still very important that they are trained on certain kind of family planning activity, like IUD insertion. Most of family planning activity are even dedicated for nurses. They discriminate against community health workers that they don't have the capacity or the skill to actually carry. I want to agree that it is important to continue to task shift because of the limited human resource we have around, and these are the people you find next to the community. And Dr. Hadiza said something about them carrying out activity outside the hospital
informal
setting.
work.
Yes, in fact, they do home visits. They go to when they see that, okay, you are supposed to come to the facility
and you don't come. They track you to your house.
And they work hand in hand with the community development committee. We call them the World Development Committee. They interact at that level. And that is why they always, you said it at the beginning of your remark, that they are like the bedrock of the primary healthcare system, and they really need to be motivated more. Apart from motivation in terms of remuneration, some recommendation, awards, motivation. And they actually mentioned it during our focus group discussion that they are not well motivated, and they are not even talking about money now. They are talking about recognition, commendation, and giving them award for a job well done.
Yeah.
Yeah.
Thank you. So in closing, I think we can all agree that the next thing to hold our government and health implementing systems accountable for, as far as community healthcare workers are concerned, if any government is interested in SDG, and universal health coverage in Nigeria, then just like Dr. Adana said, at the national level, you cannot have the community giving houses to women that are working. You cannot have the community giving food and feeding the women that are preventing us from the next pandemic, right? So we need to hold more systems accountable to the unpaid labor of community health workers in Nigeria. Because, I mean, you can't plan the health system only looking at the people at the top, the doctors and all, when we know that over 80% is delivered through the primary healthcare system and through the community healthcare workers. So if there's one thing that we can unite behind, if there's one call we can unite behind, it is the fact that this government moving forward in our policy documents, in our strategic planning for the next, 10 years, 20 years, all the years in between now and 2108, we should begin to prioritize community health workers.
Okay, so I want to mention this. I think I forgot that in my submission. You will realize that most of the primary healthcare centers, especially the hard-to-reach terrains, one thing is common with all of them. They carry out clinics for the elderly. Just like, we have vulnerable groups, a lot of attention has been put on child health, on maternal and reproductive health as they are the vulnerable. But little attention has been paid to geriatric care. And I realize that in a kind of not so structured way, these people at the health facility still try to take care of the elderly. In fact, fixing a day in a week for them as like elderly people's clinic. But now imagine if they are trained, they are built in capacity to actually take care of the elderly, aside from just, okay, let's just check BP and diabetes. You see, to go a long way in improving the quality of life of this group of people. So I want to recommend that as government, as partners, we have put a lot of attention both at the national and global level on child health, on maternal health issue. Actually put that kind of attention on geriatric health care as well. In fact, at the very lowest level of care.
Yeah.
Thank you.
Very, very important health indices indeed. Thank you very much, Dr. Hadiza. Thank you, Dr. Fatima. Thank you, Dr. Adana. It was a pleasure working with you under all those very challenging circumstances, to go into all these places, to collect the stories of these women. I'm very proud of what we've done. I am very grateful that we were able to do this together, and I look forward to more work, to deep dive more issues in the Nigeria health system through WGH Nigeria. Thank you so much. Thank you. So that was the experience of our panelists. Like we mentioned before, this was a multi-country research, 2 of them, and this one for community healthcare work was in Nigeria, in India, and in Kenya. I had an amazing time. It was tough, but we loved it, and thank you very much.
Okay, we have about 5 minutes to take questions. I have 2 already written down, and we'll take another 2 from the audience. Yes. Okay. All right. Online. Okay. Thanks to all our engaging online participants. We have questions in-house and from our online participants. But what we are going to do is a little tweak to the event. So the BMGF representatives are going to take a picture and be part of the launch. And then we're going to cut the cake in a very ceremonious way so that they can be part of that before they leave. So please indulge us. Thank you so much. So would like, Dr. Amina, I'm about to call you. Would like Dr. Kweju, Dr. Amina, and the BMGF representatives to please step to the cake. Can we make it a bit central, if we don't mind, so that...
Apologies, please. This is not, I'm not trying to cut protocol, but we're waiting for our patron, Her Excellency Mrs. Toyin Saraki, who will be here in a couple of minutes, and she would like to join the cutting of the cake. And if you don't mind, we can take the questions and just a few things, just to be sure, because she has her advance party is already here and she's on very close by.
Okay. So we go back to questions. And I'll direct it. I think the microphone can be on standby because either of the panelists can respond. I think the first question we have from an online participant is CHW an informal position? Do you require formal education?
I have no idea.
Okay. Community health extension worker is CHU, and it's the structured form, and you have to have a diploma from any college of health technology to be able to be employed either by the government or partner as a CHU. The non-structured form, which is a volunteer form of it, is the community health volunteer aid. That you might not need any form of education to be that job. But for a CHU position, you have to attain certain level of education to be able to.
Okay, so the minimum of a diploma. Thank you very much. Okay, we have another one here. Are there informal support systems for CHU that help mitigate some of the challenges highlighted? Informal support systems. Are there informal support systems for CHU that help mitigate some of the challenges you have highlighted in your conversation?
Yes, there are. The community support is actually informal. So sometimes the women groups, the men groups in the community, they once in a while, maybe monthly or quarterly, they provide support for these ones, the community health workers. Also, they have informal support group from their unions. They form unions, all those groups to support themselves.
Okay.
In this work, yeah.
Okay. So yes, there are informal support systems. Thank you very much, Dr. Adana. Please clarify that the research was only done in Nigeria, Kenya, and India. Someone is asking. Is that the case? Okay, so yes, please. I think we have the last one still around CHU. This is a bit long. Okay, so someone is speaking around the CHU ethical behaviors on the field or health facilities and due to lack of guidance and mentoring. So I don't know if there's a question there. And then there's another inherent question around, is there something you can recommend to study to be more efficient on that role?
If I get the question
Yes.
correctly, the person mentioned that ethical.
So more or less like unethical practices.
Unethical
Yes.
practices. I wouldn't say that is specific to community health workers. It can be any cadre of staff because those kind of now, just like you cannot generalize. I have seen a whole lot of very well-behaved community health extension workers, but of course, you can always see an outlier. There is always room for that, but we'll always continue to do when we go for supervision and we'll see them on the field. We'll correct them as the case may be, and that is why the local government authority, the state governments, and national sometimes, they are there to do that oversight function of ensuring that they are doing the right thing at the facility by monitoring.
Thank you, Dr. Fatima. So a balance or the other angle of the question is, what are your recommendations? So assuming there's someone who wants to improve on their skill as a community health worker, what do you recommend? Is there something they can study? Are there certifications they can be a part of? And anyone can respond, please.
Okay, for the community health extension workers, we have the junior community health extension workers, and then we have the community health extension workers. They are like the community health extension workers, they are a little bit more senior than the junior community health extension workers. But then after, when they can go and study to become chief health officers, CHOs, that's in order to improve their career.
Okay.
If I may add, there are programs like continuing medical education, training and retraining by different groups. Like this malaria, commemoration of World Malaria Day, they were also called together. Of course, they were educated more, trained more on how to use insecticide-treated nets, how to approach these, how to identify these. So the continued medical education helps them because these things are being organized at the state level. So it's an avenue to keep training and retraining these community health workers on what to do and what not to do. And when it comes to the ethics, of course, medical ethics has always been challenging, starting from communication with patients and at whichever level. But we will get there. There's no structured way to punish or say this, but doctors or maybe the senior medical officers, they have structured rules. You have a regulatory body that says this is this. But I think the community health extension workers, with what is existing, you still have to report to the LGA and then the state level. I think they will get there with what is happening.
One step at a time. Thank you very much, Dr. Adana. Okay, we have a question for the women in global health. It says, is it like an organized club or a well-structured group of people? I would like to know how a member contributes and what opportunities are available for a member.
Okay. Dr. Pedro, you probably did not get that question, so I will. So Women in Global Health is an international organization that has got chapters in different countries around the world. And Nigeria, of course, is one of the chapters, and we're launching today. So it is organized. We do have, we're registered in Nigeria now. They registered, the organized we actually do have a video from the founder, Dr. Rupert Datt, and we're going to play that video. And if the person will be patient, you'll get more information about how we started. About joining, membership is open, at least in Nigeria. It's open to anybody who is interested in global health. Even if, I'm a communication specialist, I just, happen to be working in the global health space. So you don't have to be a doctor or anything like that. So membership is open. You can sign up. We'll make all of those details available to everyone who was a part of this meeting. And we do have our meetings, and then we're also starting up a couple of subcommittees that would then allow different members to play more active roles in different aspects of the work. Yeah, so we're an advocacy organization. I don't know if I clarified that.
Yes.
Thank you.
Thank you. Another question here is, how can we strengthen the capacities of health workers to provide quality services to the communities they serve? I think it's similar to the one we had answered earlier around it not being necessarily structured, but several options were shared. If you still feel like so we had just answered it. So I imagine that this person had written it before we answered it, but if you still feel unclear, feel free to call us back on that. Do we have any participants who just want to take the microphone, make a comment, or ask your questions directly. And you can direct it to the panelists or anyone you think is in capacity to respond. I'd particularly like to hear your key takeaways from the panel as well. Things that stood out. Okay, thanks.
Thank you for the, passing the mic. This question I have is for Dr. Adana. I heard you mention that the executive secretary for your state is a female. How much of this importance of elevating the role of women in leadership do you think someone like her thinks about? Obviously she's a woman, but as women doesn't mean we often think about women in leadership. How much do you think someone like her thinks about her role as a woman in leadership in her state?
Unfortunately, she wasn't part of my participants. I really didn't, because she was the one that gave me the consent. So to involve her as a participant, I didn't really. But when we were discussing about introducing this research and getting her consent, she understood the huge gap. Even as an executive secretary, she has her own personal experiences, limitations. Even as a female, there are certain things she cannot do, she cannot say. I could remember one day while we were talking about the research, she was to conduct a free outreach. It was basically cancelled because one of the presidential candidates then was visiting the state. So she had planned the program, did everything, and just a call that was less than 30 seconds cancelled the program. So you can see that at that point, she was not involved in that decision making. She was just there to implement. So for her, she has her own. I wish she was one of my participants. I have a whole lot of them, but I couldn't use them because they weren't really working at the community level. I have doctors, those that are in the political space, that have this issue as a huge challenge. So I think if I'm to answer for her, she will represent one of my participants.
Okay, so thank you so much to the panelists. The discussion was very informative. My question, I have two out of curiosity. So from your research, what was the CHOO's major challenges? You know, you mentioned so many, but I was just a bit curious on what is the key challenge for this CHOO. You talked about promotion, you talked about remuneration, you talked about recognition, additional skills and training. So from your research, what was the main challenge for the CHOOs? And the second one is, from your research, did you encounter, you talked about it, answered it, but from your research, did you encounter any CHOO who went through the structural form, who had gone ahead to get more qualification, you know, and got promotion into any cadre higher than a CHO? So did you encounter anyone, or did you hear of anyone who went through that structure and got promotion aside CHO?
Yeah. Okay, let me respond. Okay, I'll start from the last question about if there is any of the community health workers who have attained a position higher than a CHO. Yes. In fact, one of my participants for the KII was the director of community health service at the Kwara State Primary Health Care Development Agency. She started off as a CHO. She has rose to the rank of a director at the State Ministry of Health, and she has a master's in public health. And another one of the KI also was the director of health at the local government. She also has a master in health education. In fact, there were issues. She narrated how she had issues when she was going to be appointed as the HOD health of the local governments, because that position for a very long time has been occupied by nurses. And it's not like there's anything cast in stone about the position being for it's just for any senior health administrator at the local government. So there were a lot of issues, and as it is now, okay, we have another one now, but before 3 months ago, she was the only community health worker as a director in the primary health care in all the 16 LGA in Kwara State, but now we have 2 of them. So those are the issues. And to go to the first question about their challenge. They mentioned a whole lot of challenges that they have, but one thing that actually inspired me about them is their passion. And despite all these challenges, they are still willing to sacrifice a lot for the system. One of the key challenge that they mentioned was in terms of motivation. You know, they keep emphasizing that it is not that it's about award and recognition. You know, words are very powerful. When you commend someone for a job well done, you don't need to give them money, they will be motivated. Another one is the leadership role, that they feel sidelined. And they also mentioned that even they don't have a separate union. You know, for doctors, we have Nigeria Medical Association as like a union that fights for the rights, and our voices are heard through that platform. The nurses also have that platform. But for community health worker, they do not have a platform like that. They said their platform is an allied platform of all local government, health, and health record officer or something like that. And most of them, from my interaction with them, they are not comfortable with that. They would have preferred a separate union like the one we have with the other cadre of staff, so that their own grievances could also be heard very loudly. Have I answered that? Thank you very much.
Thank you so much. Please, a round of applause to our panelists. Thank you. We're moving on very quickly. Her Excellency just walked in, and so I would run through a summary of her profile as we prepare to launch and cut the cake. Her Excellency Toyin Ojora Saraki is the founder president of the Wellbeing Foundation Africa. Mrs. Toyin Ojora Saraki is a global advocate for women's and children's health and empowerment, with 2 decades of advocacy covering reproductive, maternal, newborn, child, and adolescent health, ending gender-based discrimination and violence, and improving education, socioeconomic empowerment, and community livelihoods in sub-Saharan Africa. Mrs. Saraki has recently been appointed the inaugural WHO Foundation Global Health Ambassador. Please join me with a resounding applause to welcome her. She is our patron, and shortly after the cutting of the cake, we'll give her keynote speech. But for now, we're going to step forward and launch this chapter. Let's so right before her keynote speech, we'll have her step forward with the BMGF reps and Dr. Amina, as well as Dr. Kweju.
So I often like to catch people off guard, and Her Excellency is not an exception, unfortunately. And we won't even let you catch your breath. We welcome you, and we're wondering if you, after cutting the cake, there is a keynote address, but you know, she can just catch her breath and exhale a bit with the microphone. She has just a short word before we do that, and then have another one. Thank you.
Well, first of all, good morning, everybody, and thank you very much for inviting me. Thank you, Dr. Kweju, Dr. Amina, the members, distinguished partners, the multilaterals, and everybody who's here today. My dear sister, Vivian, and my darling daughter who's there. She always reminds me when there's an event. First of all, let me start by saying I'm terribly sorry I'm late, but the reason for my lateness today gives me a lot of joy, because it's very unusual to see 2 causes that you really care about come to fruition at exactly the same time. So I have been working with women in global health right from the very beginning. Rupa, first of all, is a very dear friend and ally. But since 2017, when we first started looking at women's leadership, it was actually in the context of finding a new director general for the WHO. And we had to make a hard decision between, do we just vote for a woman, or do we vote for somebody who understands what the intentionality about disaggregated gender data means? and somebody who will actually take that forward. And I think we were very fortunate because I was also, as an African, I was also saying, well, I want an Africa. But I think that we got somebody at the WHO who understood women, who understood gender progress, who understood Africa, because if Africa makes it, the rest of the world does better. And straight away kept a promise of 50% of a women workforce in leadership at the WHO. So first of all, we knew from that, we got some courage that it could be done. And then Women in Global Health was absolutely pivotal from that point onwards, and even more pivotal during COVID. So you all know the data. I know I'm speaking in a room of the converted, but women are actually the backbone of the health workforce in every single country. But when it comes to leadership, that's when they start reminding us, or they don't remember to give us that step forwards. And so in leadership, we're only 25%. And globally, I've worked both globally and at the front line for very many years. So globally, they used to think there was only one or two African voices. And I always said to them, I know you're looking at me. I'm lucky, I'm fortunate, I've got a platform, I'm visible, people can see me. I care about pregnant women, I care about children up to 5, and I care about girls in school. But there are loads and loads and loads and loads and loads of twins. And that's why I'm so happy with the launch of Women in Global Health Nigeria. Because if Nigeria makes it, the world makes it. If Nigeria recognizes women's leadership in health, the world would have recognized women's leadership in global health. Dr. Amina has always been an ally. She's always been the bearer of truthful evidence and researched impact that tells us when something is working, when something is not working. And it's not about apportioning blame, it's about being able to review and see the way forward. So I can't think of anybody better than Dr. Amina and Dr. Peju. We've got the intergenerational right in there, as well as having the gender. You've got the entire health profession in this room. And it is said that never doubt what a small group of people can do for an awful lot of people. So I think, I don't know how many of us are in this room today, I think there's about 60 of us. But we are trying to lead the way in policy and action and in implementation and advocacy, because advocacy is not just rhetoric. It's evidence-based persuasion, which we hope will be replicated around the country and around the world. And so I hope that the 60 that are here today, as we launch Women in Global Health Nigeria chapter, and it's a much awaited launch because we should have done this before, but COVID held us back. I hope that we will lead our 206 million people in recognizing, appreciating, remunerating, redeeming, and replenishing women's leadership in health in Nigeria and around the world. It's an absolute pleasure to launch this and to cut this beautiful cake, which shows all the achievements so far as we push ourselves harder for bigger, better achievements. Congratulations.
Congratulations. Thank you. Oh yeah, group photo then. Yes, please. Everyone is invited, please.
So we are the suggestion is to have 2 groups, right? Some people sit.
Sometimes it's unclear why it's speeding. And love, if your wings are broken, we can break through those emotions too. 'Cause I'm gonna stand by you. Truth, I guess truth is what you believe in. And faith, I think faith is having a reason. And I know my love, if your wings are broken, more minds so yours can open too. 'Cause I'm gonna stand by you, even if we break it down. We can find a way to break through, even if we can't find heaven. I'll walk through hell with you. Love, you're not alone. 'Cause I'm gonna stand by you, even if we can't find heaven. I'm gonna stand by you, even if we can't find heaven. I'll walk through hell with you. Love, you're not alone. 'Cause I'm gonna stand by you. I'll be your eyes till yours can't shine, and I'll be your arms, I'll be your steady satellite. And when you can't rise, well, I'll climb with you on hands and knees, 'cause I'm gonna stand by you, even if I break it down. We can find a way to break through. Even if we can't find heaven, I'll walk through hell with you. Love, you're not alone. 'Cause I'm gonna stand by you, even if we can't find heaven. I'm gonna stand by you, even if we can't find heaven. I'll walk through hell with you. Love, you're not alone. 'Cause I'm gonna stand by you. Love, you're not alone. I'm gonna stand by you.
After the main events, we hope that you will use this opportunity to continue to connect virtually and in person. The thing that we're doing here today, as we said, is extremely important. So we hope that the energy and the movement and the sisterhood and the friendships that come without bias. I instantly know that I'm in the room, in the right room, and you can feel that. And we hope that as we go on, we carry that along. Now, the next person I'm going to put on the spot, Her Excellency. She doesn't even know this. It's not even on the agenda. But that's how I do. I want to tell a little story about how I couldn't have imagined that I would first of all be speaking to a room of such women. And not just that I would have Her Excellency Toyin Saraki to be a patron of this organization. It's still surreal to me. There's nobody in this room that we have to introduce her to. Years and years, I grew up seeing her work. And I was a medical student in a conference. Either I was a medical student or I was just graduated. In a conference, I would say, almost about 15 years ago, I would say. I honestly cannot remember what conference it was, but I remember I was sponsored to go, so it was such a pleasure to go in. And so we're sitting in the audience, and and they said, "Oh, we have this." She was, I believe she was. Okay, I will say the story, and if you can remember. And then she came, and to my knowledge, and this is why women we need to amplify the work that we have been doing. To my knowledge, the work of health sector at that time, to my knowledge, was something that was being delivered by people in the sector, right? So I was a bit confused when she came up and she led with the story of when she had just given birth. And she said she knew that this is what she wanted to do when she had her child and she couldn't make milk. And do you remember? And some nurses came in, somebody came in and gave her some container it was and said, press. And I mean, like anyone that has it, you don't even know what's going on at that point in time. But and and they prepare you for it. You go to antenatal for it and everything, and you think you know. And her experience as a woman of privilege, and I'm going to try and verbatim say what she said, but I'm sure. But the impression, so I'm just going to remember it as I did. And she said, if her experience as a woman of privilege, her experience of maternal service delivery could have been that underserved, then what about the women that did not even have her privilege? At the time, I was just a student. I had no children, so I had an awareness of what she was talking about. I had no lived experience of it. And the two things I took away from that was the idea that this woman does not even have to be stressing herself to be here. This is not even work that she has to do, And there she was doing something that was not even, she would still be very well celebrated if she wasn't doing it. There are several women that have passed through that route and and then you say, oh, that was a shame to have happened to me, and you can move on and nobody's going to hold you up to it, and you'll be who you are in every other. So I remember, what this selflessness, and then by this time, the experience she was talking about was years, and yet an experience that happened to her, a woman of privilege, an experience she was safe from in every sense, was still compelling her to come back and do work on behalf of people she hadn't even met yet, will probably never meet in person, and yet, and then that challenged me to be even more selfless. So there's always something that you can do that does not immediately benefit you or your friends or people that look like you, right? And it's very, very inspirational to me when I meet people who don't even have to be doing what they're doing, and yet. So fast forward a couple of years later, trying to galvanize a movement for women in global health, and someone said, oh, you should definitely speak to Her Excellency Toyin Saraki, and she would be a patron and she will support you. And I was like, 2020, yes. And I was like, how? You could just, and the person said, yeah, just shoot her an email. I was like, I'll shoot her, because after that time, I've never had to see her face to face. She probably didn't even know I was in the crowd that day, right? And I couldn't have imagined that I would shoot her an email and not just get a response, but got the entire team. They climbed, and if you ever shoot her an email, let me just give you expo. If you ever shoot her an email, there are several members of the team that would jump on it and escalate it and ensure that she gets. So when I sent her the email, of course, we sent very many cold emails. So as you do, you send cold emails, and so we sent an email. When the first response came back, I didn't even know it was from your team, because I wasn't really, we were hoping for a response, but I wasn't really expecting one. So it was maybe the third from the team or the second from the team that I realized that, oh my God, we got a response. And it was really, really fast. Between when we sent the email, she was like, sure, I'll meet with you. It was 2020 was the lockdown, so she was even happy and willing to have a Zoom meeting with us. She had a Zoom meeting, and in that very meeting was when she said, yes, I'll be a patron. And it was honestly that I expected a lot of, when you in the advocacy space, you get to expect a lot of red tape. It's part of the. I was expecting a lot of red tape, and I was promised I wasn't going to get any red tape. But as you are, you just don't believe that you didn't get a lot. So several people jumped on it, and just as simply, she came to the Zoom meeting. She said, "Yes, I'll be a patron," and that was it. And it took us several years to get here. We lost ground with COVID. We lost ground also with getting us registered, but every time you've asked about us, I've heard. And the reason why I haven't been able to because it was still surreal to me. And we also wanted to make sure we got a structure in place, because you get the sense she's not someone you show up with without your stuff together. So it was more important to us to get our stuff together. At least the next conversation, we would have something together. So if somebody gives you a shot to get in the door, the first one is gratis. And then the second one, you don't want to show up exactly where, at least you need to show. So it took a while to get our stuff together. And even then, I think between her being here and the first email to invite her at all that this launch was happening was also a matter of 20 days ago, this wasn't even conceived yet. I think all of this was, under 19 days or so. The first email to HE was maybe 7 days ago. And, I fully would have understood if she said, oh, I have a lot of commitment, she's very busy. But when we got the emails back, and the other members of the team were a little shocked, but me, this was second time, so fool me twice, it's not happening. So I wanted to put that I'm very honored every time I've said something into the wild, as it were, about this movement. And every time I've said one thing, the energy that comes back, so that's how I know it's not about me, or it's an idea that the time has come. And very, very, very honored with the people I have called and have stood up for me. And especially honored to you, Ma, for doing this for us. So I will not put you on the spot again. So as you know, Her Excellency is a patron of WGH Nigeria, and she will have, if we had the time after this, because you also have to, probably let her go at some point, we will talk a little bit more about what this movement means for health outcomes for women. And, if we have the time, we'll try and project the Wellbeing Foundation and what it has done for, again, was women that don't look like her, women that she will probably never meet, women that if she didn't do it, it doesn't take anything away. So that selflessness is not to be forgotten. And I want us to, in our own ways, right, in our own tiny ways, or whatever that means, is to be able to do something for someone that can't pay you back. But every drop that you put out there is pushing and is making a difference. So with that, I would like to please invite Her Excellency to give us a keynote address as patron of WGH Nigeria. Thank you so much.
Thank you so much, Dr. Peju. First of all, I'm really, really super honored to join you today. So I can't remember what time it is, but I think we're in afternoon now. Good afternoon, everybody. I'd like to particularly greet Dr. Amina Aminu Durai, my dear sister, Country Director of Pathfinder International, all the representatives from the Federal Ministry of Health, Federal Ministry of Women Affairs, my Gates Foundation representatives that just left earlier. Dr. Peju, takes courage. It takes courage to take a global concept and make it real in a country as large as Nigeria, with a challenge as big as Nigeria's. I salute you. my dear sister Rupa Dat, who's one of my global allies and who I love, and who, like me, doesn't like too much red tape. So quite often myself and Rupa will take a stand on something globally, and we'll do it actually all by WhatsApp. And then when it comes out, people are thinking, when did they talk to themselves? My dear sister Viviane, and all the distinguished ladies who are here today. My name is Toyin Saraki, and I'm founder president of the Wellbeing Foundation Africa and the inaugural Global Health Ambassador for the WHO Foundation. I'm a longtime supporter and collaborator of women in global health, and I do believe that Women in Global Health has a committed purpose to transform healthcare around the world and in Africa. And because I have this particular focus on maternal health and championing midwifery within maternal health and nursing too, I have always taken a very intentional gender lens to promoting women's leadership in health delivery, but not just in health delivery, in health measurement, in health outcomes, and also, more importantly, in the design of the structures with which we use to deliver and drive health. So I'm delighted to join you today as we re-image and reimagine the role of the Nigerian woman in the health workforce, and we aim to achieve gender parity in global health leadership through bringing all the genders and backgrounds together to improve global health through global transformative leadership. As we officially launch Women in Global Health Nigeria today, after its establishment at a very key point in 2020, when most other organizations were actually furloughing their programs, because Women in Global Health Nigeria is led by a courageous woman, it was moving forward instead of furloughing. I would like to reiterate the importance of ensuring that the Nigerian woman in health is visible and recognized, while also being empowered to shape global health programming, policy, and advocacy in communities in Nigeria and in the diaspora. Globally, we all know that women are vital members of the health workforce, and with the male counterparts, we contribute fully to improving health outcomes for all communities around the world. Yet, while we play this significant role and we make up more than 70% of the health workforce, and you notice I don't say they, I keep saying we, because I'm a woman myself. We occupy less than 25% of the senior decision-making positions, and generally we are given lower paid positions. In the African region, women account for 28% of physicians and averagely about 65% of nurses. So in fact, the frontliners in healthcare are mostly women. Gender inequality in health stems from the inequalities in the other areas, in education, in access to capital, in political representation, in early and discriminatory marriage practices, amongst the other social determinants. In our African region, the healthcare workforce closely mirrors the background role of a woman in the community as the domestic caregiver and as the nurturer. And today I came late because I had two clashing events, but I was very, very happy that the two events clashed because both the events had gender parity at their core. The systemic barriers that we face, such as the choosing, as we all do sometimes, having to choose our family over our career, or having to relinquish training opportunities that involve travel and safety considerations, they often discourage women to follow career advancement choices. And if this continues, Nigerian women won't be able to influence sector-led improvements to the industry in which they work, as the life potential of many a Nigerian woman is affected strongly by our reproductive and familial factors, which follow us through our life course. Yet, it's not a coincidence that the Nigerian women who have risen independently in this country and globally, I could look at Chimamanda Adichie, I could look at Dante Ngozi Iweala, these are women who have actually bridged those divides and have risen to the very, very top. I think Nigerian women globally actually occupy higher positions than our male counterparts once they are able to bridge that divide and to climb that ladder. So the issue is, what is the formula by which we can make that vista of progress available to every Nigerian woman who's prepared to take the energy to put her foot on the bottom rung of that ladder. And when it comes to health, the community health worker is the true definition of the frontline health worker, as because they are the most often contacted cadre of the health workforce. Composed of mostly women, the community health worker is delivering healthcare work across the important health indicators such as maternal and child health, immunization, breastfeeding education and support, infectious diseases like malaria, HIV and TB prevention, family planning, very, very key. Yet, the proper recognition and remuneration within the health system is underemphasized, especially as maternal and child healthcare is the most accessed part of the primary healthcare system, and in Nigeria is delivered by a female workforce, but it's also the lowest paid part of the healthcare system in which we operate. So my decades-long work with the Wellbeing Foundation Africa is focused on trying to achieve measurable results that will engender safeguards for mothers, allow their newborns to survive and thrive through critical thinking, key evidence-based and real solutions, and an in-depth data-driven understanding that improves prospects of women, children, their communities, alongside actually allowing our female healthcare workers to lead, to be remunerated, to be recognized, and to be respected in the system in which they're working. Through our flagship Mama Care 360 community midwifery, antenatal and postnatal education program, we promote respectful maternity care for all women during pregnancy, childbirth, and the time after birth. And I've always believed, especially since 2014, when I became the Global Ambassador for Midwives, and I truly understood the professional capacities that a midwife possesses through her education, I believed that empowering midwifery was the vital solution to the challenge of providing high quality maternal and newborn care for women and newborn infants in all countries. In fact, it's only recently that I realized that midwives in Nigeria had not been trained on ultrasound. A partner of mine gave me 8 ultrasound machines, very expensive machines, and I took a survey of the midwives in the Wellbeing Foundation Africa, and I said, where, because they're the ones who are at the PHCs across the country, I'm hardly ever there myself, and I said, where do you want to give the ultrasound machines to? And they gave me 8 PHCs across Nigeria that did not have ultrasound machines at all. So the mothers were not able to be scanned, and which means actually that every delivery is a surprise to the delivery attendant because they don't know what's coming. And this again was 2021. So for you to know what the kind of dedication it takes to achieve a result in Nigeria and why it's so important to let women lead. So the ultrasound machines were packaged and sent off to the 8 centers. And when I sent a team round to do the monitoring and evaluation in 2022, so a year later, they were all still in their packets, which is something I'm not unused to in Nigeria. I remember as a first lady going to look at a juvenile remand home, and there was a carton there that had been, I was first lady 2003 to 2011, and this carton had been donated by UNICEF in 1976. And it had never been opened. Why hadn't it been opened? It was, I think, some workshop equipment so that they could, the children in the remand center could gain skills while being rehabilitated. And it had been donated in 1976, but in 2004, it was still there, unopened. So I decided to call them and say, please, can we open this carton? And the red tape that met me, you know, literally jumped out and bumped me on the head. They needed 5 different permissions from line directors. Anyway, they just hadn't opened this carton. By the time they opened it, it was obsolete. So when I give a donation, I actually send people round afterwards to check on the use of the item that I've donated. When they brought back the results of why they hadn't opened the ultrasound machines, first it was that there wasn't a doctor. A lot of PHCs in Nigeria don't have doctors. They have midwives and nurses, and then the doctor travels between them. There wasn't a doctor to operate the ultrasound. Then the truth actually came out. We don't know how to use ultrasound. And it was from surveying that I realized that you can go through an entire midwifery course in Nigeria and you're supposed to know how to do ultrasound, but because there's a lack of the equipment, they only teach you from the textbook, and you would never have touched an ultrasound before. And then when you get to the hospital, you meet the gender hierarchy, where it's only the doctor and the radiologist or the radiographer that can go near the, and I'm doing my chest the way they do it when they're telling the midwife that they can't enter. So it took 2 years, and I decided I was going to train midwives in Nigeria. It's a program we've just done in the last week. And I actually didn't think there would be much demand. So in Abuja, I offered my own in-house midwives and some of the facility midwives where we work, plus the facility we've donated to. Abuja was planned to be a training of 10 midwives. And the Abuja training had 58 midwives. We thought that was popular. The Lagos training was supposed to be 20 midwives, since we had doubled the number based on Abuja. The Lagos training registered 103 midwives on ultrasound, a very intensive ultrasound training, so they've now become master trainers. And then the Kwara and Oshun training should have had, I think, 40 midwives. We kept doubling the expectation as we moved the roadshow. And the Kwara training concluded yesterday and had 98 midwives. So it's not that the will to rise and lead is not there. We have to find a way to match that will with the path, with the ladder, with the training, with the measurement, and with the right tools. And that's why I would say that unlike other sectors, Nigerian healthcare does not have a woman problem. There's no lack of women entering the healthcare workforce. What we have is a women in leadership problem. The prolonged lack of investment and the systemic issues have compounded our vulnerabilities. Our female healthcare workers are concentrated in low status, low paying and unpaid roles, while facing this constant threat of gender bias and harassment. And the barriers that female healthcare workers face are undermining our efforts to realize gender equality across our entire nation. So to increase the number of women in positions of leadership in healthcare, we actually do have to build this progressive pipeline of confident girls and support systems to remunerate our healthcare workers properly, and through them build this resilient and targeted healthcare system that we so desperately need. We have seen the latest WHO data. Every time we realize a little bit of progress in Nigeria, I'm not sure what happens that takes us 10 steps backwards. So between 2010 and 2015, we actually had this massive jump in maternal survival, and we were doing very well. Between 2015 and 2023, we have seen ourselves move backwards. And I think it's only a woman, and that's why I'm really keen to support women-led action. It is only women that have the humility to come back and keep rechecking what we've done before and to check if we can do it better. And it's why it's so important to invest in female leadership and to count the women who are doing it, to recognize them and to allow the young women to rise. So when you saw me throw away the red tape, it's not because the red tape doesn't exist. It's because I was very happy that a younger generation of women is seizing the mantle to do this work. And some of my team, actually, I sometimes have to explain it to my teams. When they say, oh, but you've been working for women in global health for so long, why aren't you the president of Nigeria? And I would say, but if I was the president of Nigeria, where are we going to find the army of women in health leadership that have to carry this work? It's not about me or Dr. Amina or Dr. even Peju. You know, I glue myself to the newspapers every day to read who might be doing what well somewhere and how they're doing it, to see if we can do better. And even this breastfeeding story that we're talking about, I was delighted. The other side of that story was that after all the pressing and the howling and the screaming, my father actually took pity on me. And this is 1991. So he dispatched my younger brother that December. He had called all his business associates around the world and said, is there any way of getting milk out of a pregnant woman that doesn't involve howling and crying? And somebody in the German Chamber of Commerce said to him, oh yes, there's a little factory on the border between Germany and Switzerland. in Austria that makes something called a breast pump, but it's on the 23rd of December, just for Christmas. We're not sure they're open. And my father, to show you what can take place if you want to bridge a divide. So my father put my younger brother on a plane while I was in the hospital and said, come on, you will get down in Frankfurt and you will drive for 6 hours and you will reach this village. And they say they're making something called breast pump. And whoever owned the factory was told to go and wait in the factory because they're already on holiday. My younger brother shows up, a black man in the middle of Germany wearing a winter coat, buys this machine that weighed 45 kilos at the time and drags it back to Nigeria. They bring the machine to the hospital. It looked like something you would use to extract blood from a cow. But it actually did get the breast milk out, and my daughter survived. It's what we now know as a breast pump. 2018, and for you, I'm trying to show you the resilience of a woman. So in 2018, and I remembered the manufacturer of the machine, because they didn't sell them actually in those days. They used to rent them to hospitals. So it really took quite a bit to get one out of them to, something they were renting to hospitals to be taken to one Nigerian's house but we managed to get it. 2018, I was sitting down at a research conference. And if I think something's going to help my country, those who know me know that I can travel I can swim across an ocean if I think I will find an innovation that will help my country. So I go to this breastfeeding conference in London and I take 3 of my midwives along to learn about the science of lactation. It's not as simple as just putting the mother on the nipple. And while I'm there, I shared the anecdote of getting hold of the machine. And I noticed 2 gentlemen in the audience looking very excited. Finished it, and I was looking at all the research of buccal colostrum actually, because very few people know that first colostrum, that breast milk that we used to throw away in our culture, it's actually immunotherapy. It's the best medicine you can give to a sick child. You don't even have to have them drink it. You can just rub it on the inside of their cheek, and it really makes a difference between life and death in the first 36 to 48 hours. So I finished the speech, and these 2 gentlemen rushed towards me and invited me for lunch on the spot. And when we sat down, one of them said, I've been telling you one story for over 30 years about when I first started my factory, how I was told to go and wait outside the factory one day, and one black man just arrived and carried one machine and left. And all of you have been laughing all these years. You thought I was just telling an after dinner story. It is today we finally found the owner of that first machine. And from that, we are now working in 6 neonatal intensive care units in Nigeria, trying to build a new practice for neonatal intensive care unit lactation. So I think it's Maitama Hospital, Asokoro Hospital, University of Ilorin Teaching Hospital, Adewale General Hospital, and the Island Maternity Hospital in Lagos. They have the breast pumps, which are backed up by something called LactaHub. And we're helping the mothers of premature babies express their breast milk to be given to their children so that their children do not get necrotizing enterocolitis. Now, I'm not giving this to you as an example of leadership. I'm giving this to you as an example of the sort of tenacity that it takes to bring innovation to Nigeria, but it can be done. It will work. It will save lives, because the research that comes out of those 6 units will not only guide the rest of Nigeria in a community of practice, but it will guide the rest of the world. There's so many Nigerian women in the medical field who are doing incredible work. And only they and their immediate colleagues know about this incredible work that they're doing. So I will promise to support women in global health if you will promise to bring me back the productive promise and the achievements of what the Nigerian members are doing. Because the world needs to hear about this. And it is from that evidence that Nigerian women in global health because any health that occurs in Nigeria is global health. It is from that evidence that you will use to lead, to guide, and to teach. So many people don't know that a lot of the advances globally started in Nigeria. The use of tranexamic acid to stop postpartum hemorrhage. It started as an off-label use in the University of Ibadan, teaching hospital. Just last week, I was at the MCH Handbook launch, the implementation program for country managers on the use of the MCH Handbook. The very first, the second health record in the world, the first health record was in the 1940s in Japan. The second health record ever used globally and the first health record for measuring growth of children was in a village in southwest Nigeria. Professor David Morley. He was working in a particular clinic and noticed that the children that they were measuring their head measurement and what they were eating were doing better. I think the village was called Imesiile and the hospital was Wesley Guild Hospital, the mission hospital. And that was the first child growth chart in the world. It left Nigeria and it became Health for All abroad. And I've been working since 2006 to bring it back to Nigeria, because Nigeria often initiates things, but because we don't record what we're initiating and we don't go back to register and research and record the impact of what we're initiating, it comes back to us much like our petroleum that goes to be refined in other countries. It comes back to us like something somebody else invented, and we forget that we did it. So the Nigerian woman is absolutely unique. Dr. Peju, it's not, no meeting is random. As you sat in that conference, somebody one day had to have that courage to say, it doesn't matter what challenges we're facing at home, I'm going to stand up globally and I'm going to do it. And that somebody's you. And that somebody needed guardian angel. And that guardian angel, Dr. Amina Dorai, who has years and decades of work and evidence. And you needed a partner, because sometimes you face in-country opposition where they say, who do you think you are and what do you think you're doing? And that's when you trot out Rupa Dat, Rupa is a firebrand and I love her to bits. I respect her a lot. And then when we need an independent voice that double checks what we did before and is it really working, you can't do better than Dr. Vivian Ihekweazu in the room. When I need to check something, I reach out to Vivian. So what I want to say to every member of Women in Global Health Nigeria, the first thing we do is we drop our pride. We make sure we're all connected. We make sure we all know how to reach each other. Please drop the excellency and call me Toy, because I still have this goal. My first goal, we didn't meet it for Nigeria. My first goal was 2015. We were doing quite well, and then we had a few setbacks. My next goal, which I believe is the next goal for you all, is 2030. We have engaged with women's health leadership, and we've got to do more. We will be engaging with the UN agencies and international organizations working in health. But we all actually must commit to gender parity of being an integral part of our organizational structure, our actions, and our memories. So what I will say is, let us not forget the past, but let us use the past to craft our direction, to put our feet firmly on the ground for the future. And then the last thing I will say, I've been talking to you for 2 years. Dr. Peju, you've been sending me invitations, but you have not yet made a request. Don't be shy. Make your request and let's see how we can help you. Congratulations on the launch. And I look forward to seeing you and many, 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 many more of you. Until we count ourselves in numbers, we will not be able to dictate to the system that we must take that leadership. So we need to swell our ranks. Congratulations on this launch. Thank you.
It's hard to get me speechless because I'm a talkative. But yeah, thank you so much. Thank you from the bottom of my heart. Thank you so much. So the next part says Dr. Kweju is going to talk about the next 5 years, but no. What it is this mic is not my own, and because we're in the room with the movement, this mic belongs to anybody that wants to take it right now. As far as the agenda for the next 5 years is concerned, that's already set out in discussion. We intend to capture data even before Her Excellency came in, and that's how you know you're in the right. We had talked about gathering data. Her Excellency came in and said we should go ahead and capture data of women doing excellent work, map the work, map the contribution. Funny enough, because that's like one of our key things that we were aiming to do in the next 5 years. So that will be something that will start very quickly. Once we map the data and we map the evidence, then we can use it for what we want. And we can use it, connect it to our asks, and then implement, ensure to keep people accountable to implement our asks. So, right, at this juncture, we would like, many of us know Rupa. Many of us have not, maybe you've not heard from her directly. And after this, after I leave the mic, you will get to understand why everyone is so enthusiastic about what she's done. For Rupa, one of the things that stood out for me, because I always have a story about everybody, stood out for me is that she moves so much in her own power. And the trick of the system is to separate women from seeing themselves. It's a trick, and we have to make sure we don't fall for it. They separate you, your own, from what your own strength is. And if you refuse to be separated from the strength of what you're doing, then you're unstoppable. So it's not about encouraging women to do more, that's there, but encouraging women to actually see what they're doing. Because you're already doing it. And the trick is, they try to shift your lens away from yourself, and we're saying, no, you put the lens back on where it is. And if that's the only thing we can achieve, we're more than 50% or 70% there. So Rupa very much loved to be here in person, but because of logistics and how we had to plan, and she's somewhere else, using my favorite word, misbehaving, shaking up the system somewhere else in the world today, I can assure you that. But we have a video from Rupa. And Rupa is actually, even though she's somewhere else, she's in this meeting right now. If we showed you the WhatsApp, we should probably say hi. So Rupa, if you said hi, I'll find a way to show that to the... But this is a recorded message, but I hope it will capture the essence of what we are about and what she is about and what we as a movement are about. Are we queued up? Okay.
Hi, everyone. It's me, Rupa Dutt, Executive Director of Women in Global Health. I am so excited to formally welcome the Women in Global Health Nigeria chapter, a much awaited community. I know there are so many talented women in Nigeria and from the Nigerian diaspora all around the world. I look forward to connecting and learning and working with you and other allies from Nigeria to advance gender transformative leadership and enable women to reach their maximum leadership potential. particularly Nigeria is a significant country, not only in the African continent, but globally. As someone that has had many Nigerian friends in my life and Nigerian colleagues, it really warms my heart to be able to now have the Nigerian chapter formally part of our network. Note that you are joining an amazing community that is keen to work and collaborate with you, and together we will advance gender equality, advance women's leadership, and really challenge the estimate that it's going to take us at least 100 years to achieve gender equality. At Women in Global Health, we do things differently, and this year is particularly a critical year with the high-level meetings on universal health coverage, as well on pandemic preparedness and response, and on TB, but we also know all of these global gatherings and convenings and political moments only matter through local action. So know that you are part of one amazing network of women and allies all around the world. And I look forward to meeting you somewhere. I'm sure we will be connecting virtually. Again, welcome to Women in Global Health. Congratulations, and a special thanks to all of the leaders who have made it possible to form the Women in Global Health Nigeria. It has taken tireless efforts from so many people to make sure that this community could be launched at this point in time. Again, thank you.
Okay, so the next item on the agenda, as it were, is strategically talking about the next 5 years. And what we decided to do to shake things up a bit is to show that this is an inclusive, no red tape organization and movement. So for anyone that is in this room already, you have the same access I have to the mic. And I've held this mic a lot today. So it's over to you to speak about what this means for you and how we are proceeding together. Obviously, the more structural aspects of this meeting will be in our newsletter that we send, and we'll see what the next immediate actionable activities are. But in talking about the next 5 years, the floor belongs to all of us for the next 15 minutes. Because somebody managed to capture me by the door and told me before that she wanted to say something to the room, I would bid you very much to follow our example when, we give over the mic. You have equal access to the mic as I do. So I will first start with Nafisa Issa. Nafisa Issa is our... So please introduce yourself, Nafisa. Right there. She doesn't have much to say, and she thinks it disqualifies her from holding the mic. Say the little you have to say.
Once again, good afternoon to you all. It is quite an exciting and interesting session. Most of what I want to say, it has already been said, and I'm very proud to say I one time worked as a community health extension worker. So it is quite interesting when I heard the panelists discussing on their research study. And you see, when you look at from experience, when I was working as a community health extension worker, from our core responsibilities is to see that we delivered a quality health information and services at the grassroots level, or to say, to the local population. But yet, some of the few challenges I remembered that we faced from our school till after we graduated was most of the ethical issues, to say the ethical professional, was not taught when we were in school. So we found it a bit challenge when we are in the facility on how to interact with some of the clients or patients, or even with the community members. So it was like we have to be looking for a guidance or and how we will be mentored on how to display so many ethical behaviors, which I think it plays an extremely key role to any leadership position. Because even when you look at the current and in the National Primary Healthcare Development Agency, you will see that Dr. Faisal is not a community health worker. He is a doctor, medical doctor. And even when you look at the National Association of the Community Health Practitioners, yet he's a medical doctor. Before it was an environmentalist. I think it was currently now that is a community health and professional. So that is why I think most of these challenges on leadership position, before they may remember one or two of the community health and one or two of the community health practitioner, they always look at the doctors and other professionals. Not that we are not capable or we cannot do it. No, we can do. And sometimes, or let me say, currently we need to be mentored on so many things, especially in career advancement. Because especially at the community level, once we started enjoying that salary, we found it very difficult to, to move our career forward. Thank you. I think I have.
Thank you very much, Nafisa. The experience of hierarchy in medicine and the lack of access via training for community healthcare workers is one of the key things that the Wellbeing Foundation is targeting. And if you followed Her Excellency's discussion, it was she just decided to just cut through the nonsense and go directly to women whose increased skills could make a difference. If we decided to submit that proposal to the ministry, she's laughing already. Sometimes you have to, if you want to do it yourself, right? And if you're in this room and you've heard experience and evaluation from the Wellbeing Foundation, for instance, about how skills acquisition with no red tape. So they were expecting 40 people and 98 people showed up and they trained 98 people. Then you know that you can literally just show up and you can get those skills. What state are you in? Nafisa? You're in Abuja here. Okay. So, sorry? Yes, but where do you live? So, I mean, this is our network. This is what we do. And one of the benefits that can happen is that within this space, you don't have to necessarily go through systems that do not prioritize us as women or do not prioritize you as community healthcare workers. What else can we do with our access, if not take advantage of it like this, right? Thank you very much for your contribution. It was very, very, very... Anybody else? It's not my mic. Thank you, Dr. Fatima. Please continue to follow these. We have just about 13 more minutes to wrap this up.
Okay, thank you for the opportunity to speak. So I'll just give some recommendation about our next steps for the next 5 years. We spoke about doing more research, and I was just thinking that, for most of our activity, especially if we are working towards universal health coverage, our primary health care system is very key, and there is need for a kind of political commitment, political will on the part of the local government authority. The national government, the state government, and partners, of course, they are doing incredibly well in terms of financing a lot of disease control activity, disease prevention, and all of that. But you agree with me that at the local government level, if you want to analyze the budget performance, if at all they even have for health programs, you realize that it's almost like zero. So if we can channel some part of our resource into actually having an evidence-based fact, probably a retrospective analysis of what the budget is like at the local government level, see what their performance annually is in the last probably 5 or 10 years, so that we can actually say and propose to the government or policy maker to actually focus on this. Because as it is, the local government as a financing body for healthcare system is nearly zero, and they need to be part of this. Thank you.
Absolutely, Dr. Fatima. You be happy to know that one of our key advocacy programs for this year is UHC, and we are approaching UHC from PHC. And I completely agree with you that PHC can only be actualized and implemented in Nigeria through the local government. That's local government. Community is local government. Simple. It's really that simple. Thank you very much. It's one of the core things. I'm very proud of the research team within WGH Nigeria, my favorite people. So I'm very proud, and I hope that as we move on, we will be able to be more supported in more capacity to continue to hold the local government, support them, first of all, by advocating that the implementation should be delivered through them. And also, when we do support the advocacy for PHC to be delivered through the local government, we will also then use our data to hold them accountable. PHC evaluation, health service delivery evaluation is something that we as a body will be very, very invested in. Thank you very much. Anybody else? I will hand over the mic to somebody I feel like. We have just 9 minutes to round up. Oh, okay. Okay. You saved somebody. I was going to hand over the mic to anybody.
Thank you so much, Doctor. Can I see that? Okay. Thank you so much, Dr. Pedro. So I just wanted to also re-echo what I said in terms of capturing data. It's very important because we can use it as evidence-based tool to advocate to policymakers, so that we can address the gap facing health workers in leadership. The second one is around the example she gave in terms of the community health worker. How can we capture and bring the voices of women like that who rose, from being a community health worker to being a director in the ministry, I think primary healthcare, right? Yes, in the primary healthcare department. So how can we capture such women, in that space and maybe use them as mentors to other community health workers? Thank you.
So putting the lens or the spotlight on the work of women is very key to our 5-year strategic plan. Just like Her Excellency supported us to kind of structurally think about, we have to gather work that women are doing, research, patents. There are lots of women that are doing scientific research, social research in the healthcare sector, and even supporting more women to publish their work. There are many ways in which we as women, we auto-deselect because we're afraid, So supporting more women to publish their work. We want to support more women to be published in more journals, more Nigerian women to be published in more journals, more collaborations in the next 5 years. And also, there's the rebranding of the Nigerian female health worker. And we will want to do that by individually putting attention on individual stories, not necessarily women that are at the top, but those women at the bottom. As Toyin put them, you listed all those women, the Auntie Bolas, the Mrs. Ekanems, women that have been volunteering for 17 years, unpaid, women that have been doing stellar work, women that were involved and stellar in COVID pandemic response with tracing. Women that are still today encouraging people to still take the COVID vaccine. Women that are still today ensuring that under 5 vaccination is reaching its the target. It's not where we want it to be, but there's so many health indices that are being implemented by women that it's, so one of the things that we are going to do is to also look for and spotlight such stories, so that people really understand that women are not just are keen and are able for leadership positions. Thank you. We have just 2 more minutes and I don't think we can take a contribution, except, okay. 2 more minutes and then we wrap this up.
I think we should consider the young ones, maybe in school. I think we should catch them early. That is my own contribution. All these things we're talking about, we can get them maybe school programs, and that in that way they will be able to get into our vision.
Thank you very much. Yes, one of the things also, I promised I wasn't going to talk about the 5-year plan, but it has come out anyway. We do have, and we intend to have, beyond mentorship, which is always a good thing, we have, we have designed, in fact, and we will implement a structured internship program for young school leavers or people who are in school with very many important global health organizations. Organizations for whom they would probably never have had the opportunity to intern in. Because it is part of that knowing that you belong in that space. So if we can, and oftentimes it's because women who want to get into public or global health, especially the younger ones, are negotiating that space on their own. If you happen to find a mentor, good for you. If you don't find a mentor, what happens? But we find out that we can structurally use our power to say, for instance, we could use our power to say, we have a partnership or MOU with Pathfinder. Can we have a 6-month internship for somebody in year 4 or year 5, just for 3 months? That person learns organizational skills, learns the language, learns, say, the basics of monitoring and evaluation. It's not just important for your own skills, but it starts on your CV. And then if you want to go on to public health, when you finish, then you already have a leg in. And then instead of like just finding your way in the dark, and it's a game of 50-50. So definitely sponsored internships is something that we attempted to do in 2021. And the first iteration did not go through, but we've taken it back to the table, we've redesigned, and those structured internships we want to offer in the next year at least 5 to 5 women. Not just 5 women who are in school. We also want to do something like women that have taken a break in the life course. If you've gone and you've taken a break, because it feels again like you take a decision, and women's decisions are very unforgiving to them. And if you take a break to have a child, which is normal, all these children that we are taking a break to have belong to 2 people, but if you've taken a break for whatever reason, right, we want to make it possible for you to have to come back. It has to be forgiven to you. It has to support you to get back into that space, because that is one of the places that many women fall off and are never able to come back, because there isn't that system. So we'll be offering that to not just younger women. We'll be looking at women who have taken a break in the life course. We will also be looking at women who are differently abled. So women who are every spectrum of differently abled, because that's another way in which women fall off. So the idea is to just make sure that triangle, we are, until it becomes a square. We are just kicking the size small by small, and a bit like this. One day, it will become at least squarish. Our goal is to make sure it's a square and women are not falling off. All right, so yes, please, Dr. Hadiza. We're going over time, but this is great.
Okay, thank you. Just a recommendation about the research. I think I will recommend we carry out something like an intervention research, implementation research, which we can pilot maybe in at least 1 or 2 states where we work with key stakeholders, that's the key actors in the health care system. And then with also with the community health workers, we can do qualitative research like fuzzy cognitive mapping to explore more on the factors. And then we can also do focus group discussion to clarify the outcomes and then have dialogue groups with them. So if we do that and based on the findings from that pilot research, we can see how if it has impact, then we can advocate for upscale to other states in the country. Thank you.
We're very happy to work on that as a concept note and develop it. Thank you very much, Dr. Hadiza. So that is both the 5-year strategic plan and plenary and discussion merged into one. And that essentially brings us to the close of our launch today. And I'm going to give the mic back to Toyin, who will then introduce the very next thing on the agenda. And yeah, thank you very much.
Thank you so much. I'm hoping that we have sufficient time at the end to take one word from everyone. I feel like we need to hear that one word that stuck with us, or that one phrase. For me, I remember living audaciously. You know, he for she champions, rise and thrive. So many words jumped at me today, and I hope that we'll be able to do that very quickly as we wrap up. But just before we get to that, Bukola will give us the closing remarks. Please welcome her. Thank you.
Thank you very much, Toyin. Good evening again. Oh, sorry. We're still in the afternoon. Good afternoon again, everyone. Thank you so much for those who are still in the room. Thank you so much for still being here, Your Excellency. Thank you very much for coming and for your very inspiring speech. Thanks to, I do have a long list of thank yous to give, but, oh, okay. Nigeria will happen to you. All right, I'm just gonna go on. I would like to also thank those who have been online. We had about 120 people plus actually register for this. And personally, just in line with what Toyin was saying, I think one word that struck me today, which is probably not a word that was used, but it's the only way my brain could process it, is mentorship. Because I'm standing here right now as a product of that. Dr. Kweju literally has carried me. I'm like, how am I standing here? You know, thank you, Dr. Kweju. Thank you so much. But someone I would also really like to thank is Dr. Amina Dorayi. Thank you. Like, the Yoruba girl in me wants to kneel down right now, but I really cannot. But thank you so much, because it was an email introduction, and then I met her up at an event, and she literally hugged me and has been holding my hand since then. You know, all of this in the last few weeks. It's amazing. Thank you, Dr. Amina. Thank you for bringing the weight of Pathfinder behind us at Women in Global Health, for making, you know, you made it's possible. Like, organizations can come together and do amazing things. We don't have to work in silos. Thank you for proving that and for making sure that, you know, you helped us achieve that. I'd like to also thank Mrs. Ediri Aderebi. Thank you, thank you, thank you. You know, we started the journey and it looked like, can we do this? And she's like, yes, yes, I'll write the email. I will call somebody. And we're here today. Thank you so much. I'd like to thank Dr. Sakina Bello, Asmao, Kosi, Miriam Saleh. They're all over there. Thank you very much, ladies, for all of your help. And on the global level, we had a lot of support as well. I'd like to thank Rachel, Dr. Shabnam, Tikala, Anna, Joanne, Awa, and Nelly. Thank you guys so much. And of course, our executive director, Dr. Rupa Dat. Thank you for all of your support and encouragement to get us to finally launch this chapter. And I'm leaving the last thank you for, again, my own personal mentor, a dear friend, you know, and somebody I've come to love. It will shock everyone to know that I'm meeting Dr. Peju for the very first time today. We have never met before. I've known her since 2020. We've had communication, but we met each other for the very first time today. And it was, thank you. Man, when this woman is on your matter, you can't but excel. And I think for me, it's also a challenge, because one thing she keeps saying to me is that, Buki, whatever it is you're feeling, I need you to send that down. I need you to find somebody else, somebody younger than you, somebody who has not come as far as you have, and make sure you're also carrying them along. So she's challenging me, and I promise to always do that. Thank you. Thank you. Yes, so I guess that's it. Thank you, everyone, for being here today, and enjoy the rest of your day. Bye.
Thank you. So I hope we have our microphone to pass around. We had agreed on that exercise. I was giving us time to reflect. If we were to describe our experience in one phrase, one word, what will that be? So to buy time before the microphone is ready, some things jumped at me that I noted as well. To amplify productive results. I got that from Her Excellency's speech. You know, she says, we need amplify the voices of those who are doing good work, like the regular everyday people, right? So I hope our microphone is ready, and then we'll just take it round. It will really be nice to hear what your experience is or words in one word or one phrase. All right, you're the lucky one. Yes. Good afternoon.
Can you hear me? Good afternoon, everyone.
Good afternoon.
Yes, I'm so happy to be here, and sorry I had to step out briefly and then I came in to join. But for me, I would say it's been inspiring and educating.
Inspiring and educative.
Yes, it's been very inspiring, and I hope someday I'll be able to speak like most of the women here today. But it's been really inspiring, and I hope to find a mentor too, because I'm looking for a mentor. Thank you.
We're advertising now. Mentors wanted urgently.
Thank you very much.
Thank you so much. Next person, please.
Hello, everyone. Good afternoon. I'm very nervous, so please, if I say something. It's also been inspiring for me to be here and see women who have come very, very far in their journeys. I'm very young, 22, I'm just starting out. And my boss pushed me, she told me that I should come here and represent her. She would be here today, but she's abroad for a business meeting. So it has been so inspiring to see people that I can look up to in the health space, especially as I just started. And this meeting has been so educating for me. And I also wish for a mentor to.
It's good. Welcome on board.
Thank you.
One of the things we learned today is to allow young women rise and thrive. I hope you thrive.
You didn't say your name. Her Excellency wants to know your name, so go for it. Go for it.
My name is Grace.
Grace.
Thank you. Thank you. Vaccine Network for Disease Control.
Well done. Thank you.
Yes.
Good day, everyone.
Good day.
I thought I wouldn't speak today, but finally the mic is with me now. Okay, so far we have discussed some gaps, and we're discussing way forward, and we're also discussing what we have learned. And you will agree with me that we have mentioned some gaps like data sharing, data collection, or gathering. And we also know about the gaps in gender transformative leadership. So my suggestion, before I say what I've learned, is that because we are hammering on mentorship, and I think we should float webinars or mini trainings where women can learn from each other, not just knowing what we want, not just knowing that we need mentorship, but to where we profile women who have advanced that, so that we have little trainings where others can key in and learn. So for me today, it's been very inspiring, very exciting. It's a day we have looked up to for years. I'm so happy it has come to pass. And I wish to thank Her Excellency for coming in person. Dr. Amin, I don't want to repeat the vote of thanks, but I'm very happy today. Thank you very much.
Thank you. Thank you. One word, one phrase that has stuck with you.
All right, thank you so much. I'm happy to be here. You know, we've been planning this for a while, and I'm happy that we've been able to achieve it. Particularly, I'm happy that I came with my daughter. She's at the back, because I keep telling her that, you know, as a young girl, whatever you put your mind to do, you can do it. So I brought her so that you can hear from, you know, women, you know, in the room. And especially the fact that Her Excellency is here. Thank you so much, Ma. And I'm hoping that she's hearing me. You know, thank you so much. Pass the mic.
Where is our microphone? Okay.
Okay. Thank you, everyone, and congratulations to WGH for launching the Nigerian chapter.
Thank you.
You should have gone to the next person, but we have the daughter. So you were here throughout, and we need one word from you. It's all right, baby. One word from you, how you feel, and what you'll be taking away from this room of women today.
Good afternoon. My name is Shemilore.
Shemilore.
Yes, I am. Okay. I'm happy to be here to experience what has happened here today. Yes.
Well done. We're happy to have you.
Thank you, Shemilore. Okay, we'll continue from.
Yes.
One word.
Captivating.
Captivating.
Then phrase, I'm available for more work.
Available for more work. I love the sound of that. Well done.
So it's been an exciting experience. It's what we've looked forward to, and it's happening. So I say congratulations to every one of us. Thank you.
Thank you. Thank you.
Thank you so much. It's quite a very nice experience to meet such a group of women here. I would like to have more of this and meet more women, share their experiences and work with them. Thank you again.
Thank you too.
Hey, hello everyone. Thank you for being here. This is a big opportunity. Sorry, I can't go that fast. But yes, it's actually very captivating being here. And then the fact that we have women building women up is a great deal. When I started out, I was confused because I'm not a medical doctor, and I was venturing into health economics per se, because people always say, what is that? But when I started out, I did see people that I admired, but unfortunately I got a negative response, right? Rather than building, they are pushing you down. Like, are you going to take my position? We have decades of experience in between us, and I'm inching forward to learn from you, and you are not being responsive. So being in this group and this space, and to know that women are open to helping each other solve our problems by ourselves, I believe is very empowering. Thank you for that.
So the one word for me would be inspiring. I'm really glad to see that our individual stories cuts across everyone. We're not alone. And seeing Dr. Peju, Dr. Amina, Her Excellency share their personal stories has been, and daring to be more regardless of all of that has been very inspiring for me. So I'm really glad I was here.
Yeah, thank you very much. My name is Olubumi. One thing I would say is that it's been encouraging for me, because when I started my career in public health, it was something I didn't know that I was going to be able to venture into because of my background. But I really want to say it's been a very, very beautiful journey. And then the ability to be able to sit here with people that I might not have ever thought of meeting has been very, very encouraging for me. And I also want to thank my friend for, always very inspiring and, pushing me to be the best version of myself. So thank you.
Yeah, we're almost done now.
Hi, everyone. My name is Itoro. I think for me, it would be succession planning. This is a room full of very influential women. If we're going to be able to reduce the almost 100 years that we need for gender equality, it would be to begin to raise girls, ladies, and women to leadership positions to be able to just make those decisions that are required. So again, for me, it's succession plan. Thanks.
Thank you, everyone. We'll take 2 representatives from the registration desk.
Okay, thank you, everyone. I'm leaving here feeling re-energized. As a gender champion, I feel like leaving this room will push me to do more to continue to help young girls. Thank you so much.
Thank you.
Okay, so I think I have a lot to say, but I'll just keep it short and go to the end of what I have to say. And it's directly to the younger girls who are aspiring to be some of the women in the room, to also realize the fact that the help you need or the support you need does not meet you where you are. You also need to move towards the support, and also be ready to take that seat when it comes, and not expect someone to literally pull you into it. Thank you.
Thank you so much. Re-energized, inspiring, educative, interesting words and interesting learnings. I'll end this remarkable event reminding us that if there is anything that summarizes all that we learned today, is to have a global mindset, but have local relevance. Because in our everyday goings and comings, we meet people, we engage people, and the easiest way to amplify a voice is to start with one girl, one child, one person next to you. So to you, I encourage you, you are sitting on many shoulders that have labored to get to where they are, and you have the advantage of looking far ahead, and you have all the technology backing you. So take it up and move. The fire has started, and this exciting fire, Women in Global Health Nigeria chapter, has just begun, and is going to take over and is going to close the gap in those years that we have heard. We are not going to wait for that long to make the difference. We're starting here and now. Go ahead, please. We'll take it. No, not at all. Not at all. You're welcome to join. Let's celebrate our newest member, please. Please, can we rise up on our feet and say a simple prayer like we opened with? To commemorate this celebration, we're going to sing the national anthem and then our prayer. DJ, will you cue us in, or do we go ahead? Sorry to keep you on your feet. By the grace of God, we pray that as we have come together to know better, may we do better. Amen. May we humble ourselves to be teachable always and to be able to pass on our learnings by God's grace. And the people say, thank you for being an awesome audience.
Thank you, everyone. We're done. At the back is all the, oh, you need, how many minutes? Okay, so they're setting up, but please just walk up to anybody and network while we launch.